Here at JEC, with less than 10 minutes for a patient to have a better vision. We proudly introduce our latest technology, bladeless laser cataract surgery, the one and only in Indonesia. And cataract suites markerless surgery, specified technology at JEC for cylinder correction, less than 10 minutes for a... Also, phacoemulsification, a modern cataract procedure with the ability to make a very small incision and a comprehensive intraocular lens with the best quality. JEC provides a new technique of laser vision correction, Relax Smile. This is a minimally invasive vision correction. JEC is also the pioneer LASIK in Indonesia. In corneal transplant surgery or keratoplasty, JEC was the first eye hospital in Indonesia using laser technology as the leading edge in providing sight-saving procedure. Greater control from maximum customization. JEC provide a comprehensive treatment to children's eye disease. Equipped with a clinic that is designed to make your active children comfortable during the eye examination. Not only can eye problems solved, but appearances can be changed, such as bags under eyes. Or you may have problem with lacrimal system. All you need is oculoplasty and a reconstructive surgery to correct your eye problems. We help you to experience a better look and regain self-confidence.
JEC @Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JEC @Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JEC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JEC. Dengan layanan JEC @Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JEC @Cloud melalui kontak center JEC di 0804 122 1000, email jecloud@jec.co.id atau WhatsApp JEC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JEC. JEC @Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Good afternoon to all the professors, doctors, and colleagues. Thank you for joining us today in JEC webinar Neuro-Ophthalmology series. First of all, I would like to thank the JEC team for making this webinar possible. And special acknowledgement and thank you to Professor Angur Wang from Taipei, Taiwan, my great teacher, for making time among his busy schedule to join us today. And I would also like to send my biggest appreciation to our panelists, Dr. Yunita Mansur from JSA Orbita, Dr. Rizky Prihatning Tias from JSA Candi Semarang, and Dr. Valencia from Jakarta. The webinar today would be the last installment of this year's JSA's Saturday webinar series of 2020. It has been a quite challenging year like no other, as reminded previously through our patient safety video, especially during this pandemic era, which will always be a priority to us. So today's webinar will focus on the approach of visual loss associated with neuro-ophthalmology cases, how to diagnose and manage better among those cases. The topic of visual loss and beyond, avoiding traps in daily clinical practice, will be divided into 2 sessions, and each will be followed by a question and answer session in which the panelists will share their unique experiences in managing those various cases. Hopefully, this webinar will be a good way for us to learn for a better diagnostic approach, thus giving optimal management on several neuro-ophthalmological cases, avoiding traps that could result in late management and disaster for the patient. And on behalf of everyone involved, I hope you can all enjoy the meeting. And without further ado, I would like to invite Dr. Valencia to moderate the first session with the topic of enigmatic visual loss. Dr. Valencia, please, the time is yours.
Good afternoon, Doctor. Thank you all for joining today's webinar. My name is Valencia, and I will be the moderator for the first session titled The Enigmatic of Visual Loss. There will be 2 speakers in this session and a discussion afterwards. If you have any questions during the presentation, just type them on the Q and answer box below, and some of them will be answered live during the discussion, and some of them will be answered via chat. And for your information, this webinar also broadcasted live via YouTube, and you can also type the question at chat box at YouTube. Now, I will introduce our first speaker, Professor Angur Wang. We are very delighted to have you as our guest speaker today. Professor Wang is one of a distinguished neuro-ophthalmologists in Asia. Currently, he is the head of Neuro-Ophthalmology and Strabismus Department at Taipei Veterans General Hospital, Taiwan. And he also served as a Secretary General of the Asian Neuro-Ophthalmology Society. He will be delivering the tips and tricks for recognizing functional visual loss. Without further ado, I will like Professor Wang to share his screen and start the presentation. Hello, Prof.
Hello. Can you see my screen?
Not yet.
Not yet.
Okay, now we can.
You see it now?
Yes.
Okay. I would like to hi everyone in Indonesia and also in Taipei, and I'm happy to join with the Jakarta Eye Center webinar, and I want to thank Dr. Alia Arenti for inviting me to join with you. And it's very happy to talk about functional visual loss. That's one of my favorite topics, and today I'm going to talk about the tips and tricks in managing the functional visual loss. For the financial disclosure, I have no financial interest to disclose. And Functional visual loss is a decrease in visual acuity or visual field, not caused by any organic lesions. It's a matter of won't see, but not can see. And it consists of two main categories. One is the hysteria. It is associated with unintentional and fight symptoms. And the other one would be the melancholy, which is the intentionally fighting of symptoms. Let's look at our cases. Case one is a 41-year-old female pianist, and she had a past history of optic neuritis. And in 2006, she complained about diplopia and low limb weakness. Visual acuity was 630 in the right eye and 660 in the left eye. Prism cover test showed 2 prism diopter of exotropia with full range of motion. Visual field test showed constriction in both eyes, which is compatible with the clover leaf patterns. And the MRI of the brain was negative in all aspects. And in 2010, she came back again, and this time she complained about diplopia and blurring. Visual acuity was 660 in both eyes. Prism cover test was orthophoric in both eyes, and the extraocular movement was full. And when we occlude his right eye, the diplopia persists. So she had a monocular diplopia in her left eye. And the anterior segment was normal, fundus was normal, and the visual field test showed some superior ocular defect in both eyes. And the GDX examination at that time showed a relative normal nerve fiber layer in both eyes. And the MRI of brain was negative in this lady. 1 year later, she came back again, and this time she complained about blurred vision in both eyes. However, her visual acuity improved to 610 in the right and 612 in the left. And she can identify 4 color plate using Ishihara test. And the fundus examination was still negative. And the visual field test showed a superior temporal quadritanopia in both eyes. Her MRI of brain was negative. Over many years, we were unable to detect any lesion in the optic nerve and the brain by MRI or by GDX. Nevertheless, she had received many times of pulse therapy and a long-term steroid treatment by the neurology department under impression of multiple sclerosis. Later, she developed compression fracture of the L1 spine and became wheelchair bound. So conversion disorder is mainly caused by psychological factors. It is associated with unintentional and fight symptoms. One or more symptoms may affect voluntary motor or sensory functions. It may clinically mimic neurologic or medical diseases. Management of the conversion disorder mainly consists of explanation and suggestion. Psychotherapy or hypnosis may help as well. Did you ever lie? Lie is actually a human trait. Let's look at case 2, who is a 9-year-old Indian American boy who lived in Taipei. He complained about blurred vision in both eyes for 2 months. In the past time, she has a regular checkup at school examination every 6 months. However, in recent 2 months, he complained 6 blurred vision and found to have a 615 visual acuity noted at school. And so he was brought to another local hospital. There, the visual acuity was 630 in both eyes, and the visual field showed relative superior ocular defect in both eyes. OCT showed an average retinal nerve fiber layer thickness of 109 in the right and 88 in the left. He was referred to us under impression of visual loss with a known cause. And in our clinic, the visual acuity was 612, 620 in both eyes. And the prism cover test was orthophoric in both eyes. Anterior segment was quiet, and the pupil response was normal. And you can see the fundus, there's a relative a little bit enlarged cupping in the left eye, and we do the OCT again. Here we found that average peripapillary nerve fiber layer was 109 in the right and 94 in the left. Visual field shows some focal defect in both eyes. So for this case, I think maybe there is some juvenile possibility for juvenile glaucoma. However, visual loss is not likely. So we decide to perform the visual acuity test at different distances. At 6 meters, he can identify the third line on the Snellen chart. And when we change to 3 meters, he can still only identify the third line on the Snellen charts. So we decide to move on to do the eye drop button-up test, but not the red wine button-up test. The eye drop is we call that a magic eye drop. We told the boy that magic eye drop may improve your vision, and take the eye drops and wait for 15 minutes with your eyes closed, and then we will examine it again. After 15 minutes rest, and we check the visual acuity from the smallest line in the button, and with persistence encourage him that you can identify these small lines in the prior test. So we call that the eye drop button-up test. After the eye drop button-up test, his vision was found to be 6/6.7 in both eyes. So at this time, we can be sure how good he could see. And for the treatment, because there's not much evidence about glaucoma, so we decide to discontinue the use of Timopto, and we suggest his parents to have a complete visual rest. Avoid any television, iPad, or cell phone use, and come back 3 weeks later. 3 weeks later, the boy rushed into my clinic and told me, doctor, my vision has fully recovered. And the visual acuity was 6/6 without any correction in both eyes. And also, we are not quite sure about his glaucoma condition. So we checked the visual field again 3 months later. As you can see that there is still some focal lesion. However, it does not look like a glaucoma. So for malingering patients, visual acuity performed at different distance is an important and good screening test. Eye drop button-up test and the visual rest therapy would be especially helpful for the kids. We should avoid confrontation and remember, do not miss any organic lesions. So Pablo Picasso has said that art is a light that enables us to realize the truth. However, for me, light is an art that enables us to realize the truth. Let's look at case 3. Case 3 is a 46-year-old female lawyer, and she complained there is an inferior temporal field defect in the left eye. She noticed that in the March 2015, and 5 months later, she visited another local hospital and showed there is really indeed an inferior temporal defect in her left eye, and she had past history of hyperthyroidism. This is the visual field test she had been doing in the local hospital. You can see there's an inferior temporal defect in the left eye, and there's also some temporal constriction in the right eye. During this period, she received several examinations. The central vision seems to be intact, and the fundus looks good for me. And the OCT for the glaucoma OCT and also the macular OCT were show intact macula and intact nerve fiber layers. And she rechecked her visual field again in the local hospital. This time, the inferior temporal defect became a complete inferior temporal quadritanopia in the left eye. She also received the brain MRI, which was normal by the local hospital. And then the patient was then referred to me because nothing was found. So the patient came to my clinic, and after exam her test results, I suggest her to do a binocular visual field with both eyes open and using the 30-degree program of the left eye. And here comes the results. There is still a left inferior temporal defect in the left eye, in both eye programs. And so I spoke to my fellows. How would she have this inferior temporal defect with both eyes open? And then I turned back to the patient, said that with under current condition, we can only observe your condition, and we were unable to do anything more. Please come back 2 months later. And the patient lost follow-up after the binocular visual field test. I believe she has noticed something. So the automatic parametry is quite easy to fool, and a patient can produce any type of visual field defect. For a patient with monocular defect, we may try to repeat field test with both eyes open. If the patient produces a similar or missing half defect, then a non-organic component is present. Case 4 is a 38-year-old tattoo man, and he complained blurred vision after trauma. And he had a right eye injury by iron tube 1 month ago, and he received primary repair of the conjunctival laceration at another hospital. However, he suffered from persistent blurred vision in the right eye since ever then. And so he was referred to me by the doctor next door under impression of suspected traumatic optic neuropathy. Visual acuity was 660 in the right and 6/8.6 in the left. And the zero color plate was identified in the right eye. Anterior segment was quiet. However, the pupil was already dilated by the referring doctor. The fundus picture showed only a little bit tessellated change in both eyes, and the disc still looks pink for me in the right eye. Visual field was nearly totally obscured in the right eye, and there is a superior ocular defect in the left eye. So the patient was admitted for the CT scan of the orbit and prepared for steroid pulse therapy. CT report came back the next day, and it was normal except for some sinusitis. So on the next day, we begin to check the pupil. Whoa, there's no RAPD. So we decide to do the visual acuity test at different distances. His right eye can identify the second line on the Snellen chart at 6 meters. At 3 meters, he can still only identify the second line. So we decide to move on for the fogging test. Usually we will put the +5 or -5 sphere on the bad eye and put the +5 and -5 cylinder in the so-called good eye. When we rotate the sphere lenses, the chart will be still very clear. However, if we rotate the cylinder lenses with their axis 90 degrees apart, the chart will become very, very blurred. So for this man, we first check a baseline acuity with correction of his myopia. And the result came out to be 6/15 in the right eye and 6/7.5 in the left eye. Then we sorry. Okay. So then we put on the sphere on the right eye and the cylinder lenses on the left eye. And first, I told the patient that I'm going to examine the right eye with her both with his both eyes open. And the result came out to be 6/15. So it shows that the patient pretend unable to see. Then I told the patient that I'm going to examine the left eye. And at this time, I'm rotating the lenses and rotate both lenses. And you can see that the right eye can still see clearly. And however, when the left eye was with the cylinder axis 90 degrees apart, he cannot see clearly. And the result came out to be 6/7.5. So at this time, I'm quite sure that his right eye was able to see at least 6/7.5. So I'm in a really bad condition that I found out the tattoo man was cheating. And however, he was already admitted. Should I tell him that I found out he was cheating? I think honesty may be the best policy, but however, would that be best for the doctor or for the patient? I choose to inform him that he did not pass the malingering test and suggest him to be discharged without any further treatment. He and his wife then asked me for a medical certificate. I told him that I will have to put on the diagnosis of malingering if he insists to have the certificate, which could be harmful for his records. He was then discharged without any medical certificate, but he came back the clinic 2 days later and insists to have the certificate since his insurance agent told him to do so. And I talked to his agent on the phone and said that the diagnosis would be malingering, which could be harmful and useless. His insurance agent said that, "Don't worry about us. I have been doing the insurance agent for over 20 years. Just give him the certificate." So he got my certificate of malingering. And I believe he is the first one and the only patient who get the hospital-approved certificate of malingering. 2 days later, I got a complaint from the client service department. His wife said, "How come is the diagnosis would be malingering? That would be harmful and useless and let us have a poor records." So we should remember to avoid confrontation. Always do the malingering test in the office, not until after the mission. In the malingering condition, I told the patient every examination came out to be normal. So for the kids, you should have a visual arrest. But for the smart lawyer, I told them every examination came out to be normal, so we should keep our observation. At the same time, give the patient some hint that the doctor might know something, so the patient will disappear by themselves. And for the stupid tattoo man, I told them, every examination came out to be normal, so I cannot issue any certificate to you. In the condition of a conversion disorder, I told them something went wrong, but it will recover soon. This kind of management can relieve the stress for the pianist and also avoid unnecessary medication. So in this cartoon, the mother dog teach the puppy that they will give you a lot of treats while they are training you. So play dumb as long as you can. So for me, the functional visual loss, especially the malingering, the patient pretends seeing nothing and the doctor pretends knowing nothing. Thank you for your attention. I hope the audience will not pretend learning nothing.
Thank you for your presentation, Professor Wang. It was a very practical and a concise presentation. We will continue the second presentation that will be delivered by Dr. Alia Arianti. Can I have the vitae, curriculum vitae of Dr. Alia? Dr. Alia works as an ophthalmologist at JEC Eye Hospital and Clinic. She has finished several neuro-ophthalmology fellowships abroad and currently an active member of Indonesian Neuro-Ophthalmology Society and Indonesian Association of Clinical Electrophysiology of Vision. Dr. Alia will be presenting about the multiple modality of diagnostic tests to explore the visual loss problem. Please, Dr. Alia, the time is yours.
Thank you, Dr. Fallen, for the kind introduction. So I would like to share my slide. Okay, so today I would like to share our experience on using multimodal diagnostic tests in our clinic to explore the cause of visual loss. So I have no financial interest to disclose, and from time to time, we get referred to our clinic for patients with visual loss, but the anterior segment and posterior segment examinations were within normal limits. So we need to find the cause of the visual problems. And of course, we need to start from careful history taking, continue to clinical examination. So we need to make sure of the actual complaint first, whether it is actually a visual loss or other symptoms that might mimic visual loss, such as diplopia or oscillopsia, and what is the characterization of the visual loss itself. Not to forget, explore the past medical history and the familial history, and in particular in Indonesia, because it is an endemic area for tuberculosis, we might want to ask for possible exposure to toxic substances, including ethambutol. Afterwards, we need to go through a thorough neuro-ophthalmic examination one by one, but pay a little more attention to the afferent system examination and also the pupil examination, including size, reactivity, and RAPD, and then moving on to perform the visual field testing. So the simple rule is that for every patient with blurred vision, they should at least have been examined for confrontational visual field test, RAPD, especially in unilateral or asymmetrical cases, and formal perimetric testing if either of the two is abnormal or if the visual loss degree does not match the examination. Why is it very important to perform this? I would like to just remind you a brief reminder for the visual field defect and how the retinal nerve fiber layer axon is organized in the retina, all the way to the optic nerve, optic chiasm, and to the retrochiasmal pathway, all the way to the visual cortex. So any lesion in a specific location might produce specific type of visual field defect that might help us differentiating the cause of the visual loss. So this is a very good example of why we need to perform visual field examination. So an old male patient came with blurred vision of both eyes, unaware of the onset and non-specific characterization of the visual loss. Ocular examination only revealed mild degree of cataract and the visual acuity was quite good. But when we performed the visual field test, the patient revealed to be having a combination of left homonymous hemianopia and the right incongruent superior quadranopia due to right occipital infarction and an old infarction of the temporal occipital lobe. So in patients with hemianopic visual field defect, they can have a perfect 20/20 vision while the eye appearing normal. So visual field testing and RAPD and other neuro-ophthalmic examination might help us identify the location of the pathway. But sometimes, even after meticulous examination, we might need specialized ancillary testing to help us find the location of the lesion. So patients with subnormal visual acuity with no apparent abnormality might fall into the category of anterior segment abnormalities or amblyopia, or occult retinopathy, or optic neuropathy, and chiasmal and retrochiasmal problem, or as previously mentioned by Professor Wong, functional or non-organic visual loss. In order for us to differentiate those, we need to explore a good visual function test, and not to forget perform the RAPD and the visual field testing, and then decide what kind of ancillary testing might be useful and helpful in trying to determine the location of the lesion, and then go on to decide whether the patient needs neuroimaging or not. This pathway would help greatly in differentiating between retinopathy or a more posterior problem, even for functional visual loss. So the type of in-office setting testing that we might get our hands on and might be useful would be OCT, fundus autofluorescence imaging, FFA, and all the way to the visual electrophysiology. It can help us in differentiating retinal from optic nerve disease and to detect subtle structural abnormalities. And then we can decide whether the patient needs to be referred out of office for neuroimaging or not. So I would like to go briefly on two types of tests that might help us greatly in this kind of settings. The first one would be the OCT, because it helps us monitor the structural abnormality. Throughout the recent years in neuro-ophthalmology clinic, OCT has gained its popularity for evaluation of patients with neuro-ophthalmic condition, because it gives us a structural and quantification of thickness of both the retinal nerve fiber layer and the ganglion cell complex. So it helps us for follow-up and assessment of several pathologies of optic neuropathy, and it helps us correlate structure versus functional defect. It helps us in prognostic valuation and confirm the presence of abnormality or pathology. It helps us identify neurologic lesions, and also it helps us detect oculomacular problem. It's actually a very useful supplemental tools in office in an outpatient clinic. So, for example, OCT can be used for assessment and follow-up of several pathologies. So I would like to show you a case of idiopathic intracranial hypertension. On first presentation, the patient came in with severe papillary edema, which was confirmed by the OCT of the optic nerve head. You can see here the NFL thickness on right eye is more than 390 micrometer, and on the left eye is about 370 micrometer. And all quadrants of the NFL is really swollen. Over the time after treatment, clinically we can see the papillary edema subsided as confirmed using the OCT with the decreased thickness of the NFL layer on both eyes and in all quadrants. Also, one of the clinical use of OCT would be to clinically correlate between the visual field defect and the structural loss of the ganglion cell of the macula. This is very useful if you have this feature on your OCT. For example, for chiasmal compression, you can see that in the eye with the temporal hemianopia defect, the right eye, there's a correlation of the loss of the GC-IPL complex on the nasal side of the macula, because remember that the optic chiasm, the nasal retinal nerve fiber is crossing through the chiasm. So it's actually produced through a mechanism called retrograde degeneration. You can also use this to monitor other pathologies such as in NAION. You can see that this is a typical NAION with inferior altitudinal defect of the right eye. And you can see the NFL on the right eye, the superior part of the NFL of the optic nerve head is thinning. So it correlates between the functional and the structural defect in this patient. It also helps us to identify neurologic lesion. For example, this is a patient of progressive bilateral visual loss, whereas on the left eye, positive RAPD. But because on the first examination, we was not able to perform a visual field test in this patient, we chose to put the patient on the OCT examination to examine the ganglion cell layer on the macula, and we can see both of the eyes have had thinning of the nasal side of the ganglion cell complex, which might be due to compression of the chiasm, as confirmed by the neuroimaging in this patient. And of course, it helps us detect subtle maculopathy, such as in this patient. She was a young female referred for possible bilateral optic neuritis, but on OCT, you can find that this is a normal OCT of other patient. You can see that the inner outer segment junction of the retina is supposed to be well defined like this, but not in this patient. So you can see this is the IS-IS junction. On both the right eye and on the left eye, around the foveal area, it's missing. So it is actually a macular problem, a macular dystrophy thought to be due to Stargardt disease, not optic nerve problem. So it would save so many time and a diagnostic procedure for that patient. And the second test I would like to explore just a bit is the visual electrophysiology test, because for OCT, it detects structure. For visual electrophysiology, it detects function. So it's a great combination for using both of them because it can help us provide evidence objectively of dysfunction and identify the site of this dysfunction itself. The two most commonly used visual electrophysiology testing would be ERG and VEP, each having specialized types of examination to detect special part of the anterior the visual pathway from retina, macula, ganglion cell, all the way to the optic nerve to the primary visual cortex. So it's best to combine both ERG and VEP to try to locate the pathology of patients with unexplained visual loss. We prefer to use the corneal electrodes as possible because it gives us the greater reading. And as previously reported by other studies, the use of visual electrophysiology in neuro-ophthalmology clinic is helpful in more than 90% of cases to help differentiate between normal or presence of retinopathy or post-retinal problem. Our hospital, we conducted a brief study by Dr. Valencia. It helps us confirm the presumptive diagnosis in 74.4% of subjects. So this is a case of visual electrophysiology used to identify the problem or showing a lack of problem. So this is a patient, young female patient with sudden visual loss of both eyes, feared to be having optic neuritis, visual acuity of 1 meter finger counting, but other was not so convincing. So fundus appearance is normal. So we decide to perform the ERG to convince the patient of the condition of the patient, and both retinal function and the macular function was within normal limit. So was the VEP. So this is the normal standard of VEP examination, and this is the right eye and the left eye of the patient. If the patient really had a visual acuity of 1 meter finger counting, there's no way that the wave that is produced in the smallest pattern reversal VEP would be as normal as the control. So the patient actually came in with a functional visual loss and not optic neuritis as previously thought. It also helps us differentiating neuro-op versus non-neuro problem. This is a case of a female, young, 22-year-old patient with sudden blurred vision and lost a partial visual field of the left eye, with no other significant findings and was referred for a possible optic nerve dysfunction. So visual acuity was good, RPD was not present, but this is the visual field test finding. So the patient was referred to me already having MRI examination, which was normal. So we decide to re-explore the OCT. Here you can see the macular OCT showed a loss of IS-OS junction on the nasal side of the left eye, which was confirmed using the ERG. Both a full field and multifocal ERG showed presence of depressed response on the nasal side of the macula, which confirmed the presence of left eye maculopathy. So this was actually a case of retinal disease masquerading as an optic nerve disease, possibly due to acute idiopathic blind spot enlargement. So we utilize ERG and VEP to detect the presence of maculopathy. Some other tests I would like to mention just briefly is that we can use fundus autofluorescence imaging to detect subtle maculopathy, help to differentiate from optic nerve problem, and also we can utilize FFA to differentiate several types of optic disc swelling from papilledema to NAION, AAION, and liver. So in conclusion, remember that patient with what seemingly to be unexplained visual loss, there is almost a logical explanation for it through careful history taking, high index of suspicion, and thorough clinical examination, combined with appropriate testing. So it's best to combine both structural and functional evaluation in this kind of cases. So I hope you're not confused, and my message is that to never give up in finding the cause of visual loss in your patient. Thank you for your kind attention.
Thank you for your great presentation, Dr. Alia. I think we will move on, continue to discussion session. In question and answer box, we have one question. I think it's can be answered by Professor Wang and Dr. Alia. Let me read the question. I'm working as a company doctor in a gold mine project. It's quite far from the hospital, and during the COVID-19 pandemic, the policy of the company, if someone leaves the mining area, they must quarantine for 14 days. And the doctor have a patient who complained with sudden visual loss, but only during nighttime. And this guy works as a heavy machine operator that have to shift day and night shift, and the patient asks the doctor to put only for day shift. But from medical history and physical examination as a general practitioner, there is no significant abnormality. He asked whether he should make a recommendation to make the patient only work at day shift or refer this patient to ophthalmologist. Maybe we can start with Professor Wang, if you have any thoughts about it.
I think sudden onset of visual loss in the nighttime would be very rare. And I think, however, the patient didn't have any ophthalmological examination, so we don't know his basic data about like visual acuity, and also as Alia has introduced that we in current analysis we should have a OCT examination to check the retinal condition, if there is anything lost about the outer retinal segment, and also maybe an electrophysiology test that can help us to evaluate the rod function, so that we may know the night function for his retina. And with this data gathered, we can have a first impression of this patient. So I think although the functional visual loss in this patient cannot be ruled out, I think the patient still needs some basic eye examination.
Okay. What about Dr. Alia?
Yeah, I would like to agree with Professor Wang on this. I think it's better to just make sure and refer the patient to a local ophthalmologist to make sure that there is no problem. Although it's quite rare for specific like that type of specific visual loss only during nighttime acutely. So, but it's better to be safe. But I think I have a question for Professor Wang regarding this case. Do you have any tips or a very simple examination that probably the doctor that is handling this patient can perform in the setting of no fancy testing available in the clinic? What would you like to recommend for him to explore on the patient?
I think if you don't have any tools in your practicing places, I think usually the night vision would be related to the rod function, and which is highly correlated with peripheral retina, because the rod cell is majorly located over the peripheral retina. So if the night vision is lost, usually the visual field is also lost at the same time. So attention screen would be这个 confrontation test would be a very useful test for this kind of condition. And you can first check some confrontation test if he can identify the peripheral vision. And if the peripheral vision is good, then the night vision is bad. That would be very rare for this kind of condition. And also for the confrontation test, you can test at different distances. So usually the field will be enlarged if you double the testing distances. So that would be also helpful for you to differentiate organic lesion from a functional loss in this kind of condition.
So basically we need to differentiate tunnel vision from funnel vision, right, Professor Wang? So in patient with non-organic visual loss, the degree of the visual field constriction would remain the same in various distances, right?
Yeah, yeah.
Okay.
Okay.
I think we have another question from our speaker, Dr. Rizky. She asked whether when is the best time to do electrophysiology test in a patient with suspicion of malingering. Maybe it is the last modality or maybe the first one, because we live in a defensive medical era where we should give quite clear evidence for patient that your visual function is good or not. Maybe Professor Wang can answer first, and then Dr. Alia can add with.
Actually, Alia will be the expert for the electrophysiology.
No.
And Alia has been in Taipei for several months, and she knows that I rarely do the VEP examination for the functional visual loss, because the patient would be easily pretending he saw nothing, and if he does not look at the monitor screening, and so the VEP will be very bad. And so you must make sure that the patient has already looked at the monitor, or otherwise the VEP test would be not very accurate in assessing a functional visual loss. However, in several conditions like occult macular dystrophy, you will see nothing from the fundus, and you will maybe the abnormality for the outer retinal segment will be very, very minimal on the OCT. And the visual field test, if you are doing the 30-2 program, that would be negative. In this kind of condition, the visual acuity in this patient would be 6/60 to 6/30. In that kind of condition, you would suspect the patient would have a functional visual loss. And in this kind of condition, if you are going to do the electrophysiology, sometimes it will help and sometimes it won't, because that would be a occult macular dystrophy, which means even the electrophysiology will be negative for a full field ERG. However, if the patient is old enough, like he has going on to his 30s or 40s, then the electrophysiology may have some change in this kind of condition, and also the fundus picture and the OCT will more likely age-related macular degeneration. So that depends on the patient's condition. And I think maybe another condition is like cancer-associated retinopathy, and in this CAR patient or the MAR patients, and the retina may looks fine on the OCT. However, in this kind of condition, the ERG will be extinguished, and you will have a flat rod response and the flat cone response, and then the first impression come to your mind would be maybe that would be an autoimmune cancer associated autoimmune retinopathy. So that would be the condition you will have to use the electrophysiology, although the anatomy and also the OCT will be all looks fine for you. And so that will be depending on the condition when you are going to use the electrophysiology.
Yeah, I would agree with Professor Wang on this. So in terms of functional visual loss, I don't, so I would prefer to prove the non-organic nature of the visual loss by clinical examination first. We can use the testing that Professor Wang has previously described. We can also use the base down prism examination, several types of examination. And then if the patient needs some affirmation, or the case that I'm showing you the example before is a case of a 5-year-old girl in which her parents are very worried about the condition. So I need to make sure that objectively there's an evidence of non-dysfunction in this patient. So that's why I opted to perform the ERG and the VEP on the first occasion, because the patient was the parents of the patient was really anxious, but clinically the degree of the visual loss and the gesture and the of the patient does not match. So the patient, when she first came into my clinic, she can actually spot something behind my chair, a small toy. She pointed out the toy over there. So I was like, okay, this is probably nothing, but because of the patient's parents are really worried about the condition, because she's very small, just 5 years old, and it will be quite difficult for me to clinically prove the presence of non-organic visual loss. So I tried to perform the electrophysiology, which was shown to be normal. So hopefully in this kind of cases, because the patient is quite small and cooperative, she wouldn't understand how to manipulate the fixation to get a bad result of the electrophysiology testing. But I think Dr. Valencia also have a previous experience on these kind of cases. I remember that you had a patient with functional visual loss.
Yes.
It was confirmed by several testing, including electrophysiology, which was normal. So the patient had an NLP. She complained of a no light perception visual acuity, right? But the ERG and the VP was normal, and the same on both eyes. So it's not possible for a no light perception visual acuity to have a result of a completely normal examination like that. But on the second time we tried to reperform the electrophysiology testing, he had found a way to kind of play on the fixation, hence resulting in the worst result of the electrophysiology. So yeah, we need to be really careful on examination for electrophysiology testing in this kind of patient, because some are quite cunning and they know how to just manipulate things to get a worse result out of the testing.
Like Professor Wang said, we have to be there on the visual electrophysiology test and make sure that the patient look at the monitor. Yeah, I think the Dr. Andika who asked about the question before, he said that the confrontation test was normal in some distance. Maybe I think the concern will be if the doctor send this patient away from the project. He must be quarantined for 14 days to be back into the gold mine before he can work again. So he have to be very careful and responsible for this decision, whether he wants to ask this patient to go outside the project or not. But still, yeah, I think Professor Wang and Dr. Alia agreed that this patient should be assessed first with the local ophthalmologist nearby.
Yeah, agree.
Okay.
Yeah, me too. Yeah, it's quite a difficult time this year. So every clinical decision is somehow affected and influenced by the fear of catching the COVID-19 disease. So yeah, it's quite difficult, but still necessary though.
Yeah. And also, Professor Wang, it is very interesting in your presentation that you said there should be no any confrontation when we're dealing with patients with functional visual loss. What about your experience? Did you encounter many cases of functional visual loss? And from your experience, you said no need to confront, but once in a while you have this patient who is very insistent and persistent when they're having visual loss, but we cannot find anything wrong with them. How do we take care of this patient without confrontation?
Yeah, especially as you can see from the from my presentation, that the last case, he was encouraged by his insurance agent to have the certificate, and he was already admitted into the ward, and I have the obligation to issue the certificate to him to at least have an answer for his admission. So in that condition, for the long run, I think he want to get some financial reimbursement from the medical certificate, and either from the insurance company or from the legal from the court, and so for to prevent from getting into their legal issues in the future. So I decided to give him the real answer about he did not pass the malingering test, and so that I can get away with this trouble. So that would be a small confrontation for a short time. In the long run, the patient would disappear from your clinic. If you try to issue the medical certificate, such as suspecting traumatic optic neuropathy to him, then the same story will go on, and he will keep in your clinic for a long time. And when every time he go to the legal confrontation, he will ask you to give him a new medical certificate. That would be a long-term problem. So I have in that case, my problem is that I admit him without checking the RAPD sign, because the patient has already been dilated by the referring doctor on that day. So maybe the better way is that ask the patient to come back the next day, and then to check the RAPD sign, and even you can check the Fogging test in the presence of a dilated pupil. That will also help as well, although not so accurate. As long as he's pretending, so he will be pretending, seeing nothing, whether his pupil is dilated or not, I think. So you can still use it. So we were trying to avoid any confrontation. Like for the kids, he was challenged to use the bottom-up visual field acuity test, and he was put on the visual rest, and he came back with his vision fully recovered. I did not disclose his condition to his parents, and his parents was very satisfied with the therapeutic effect. And the patient has grown up to a handsome young man now. He's in college, and he visits my clinic every 6 months, and he's very happy. And his mom is currently my patient too. So I think that kind of patient-doctor relationship can be kept, and also we have a good interaction with each other, and then there will be a going on and a good relationship and a good future for each of us. I think that would be important when we are managing the functional visual loss. However, on the other hand, such a such as a smart lawyer, and you may trying to keep good relationship with her, and but at the same time, let her know that you know something, and let him feel that you know something, and so he will get lost from your OPD forever. He will not. He will not come back. She will not come back because she knows that you know the truth. So, but you don't need to confront with her. So that's the way how I manage the money injury patient.
And have you ever advised the patient with conversion or malingering to go to the psychiatrist or psychologist like that?
Actually, I didn't do that, and I think uh, for the pianist, I think she has a lot of stress, and she should go to the psychiatrist, and we would suggest her to do so, but that would depend on her own choices, and we will try to comfort her that there's no big deal and she will recover soon. And I think that would be the better way to relieve her stress, either by the piano performance or something else. I think that's the underlying cause for her flare up of her symptoms. And every time when she had that kind of attack, such as a blurred vision or diplopia, she must be under tremendous stress for the piano performance, and then she on that condition she was usually sent by her family to the emergency room. In the emergency room, the doctor over there would say, think, oh, she had a blurred vision, and she had numbness in the hands and in the mouth. Actually, that could be a kind of hyperventilation. And however, that will be interpreted as a numbness and weakness for the extremity. That will be a sign for the multiple sclerosis, and so go on for a steroid pulse therapy. So she received over 10, 20 times of steroid pulse therapy during her second and third decades. So that's why she got the compression fracture of her lumbar spine. And however, from the MRI of her brain and the spine, you find nothing for demyelination, just the psychological problem. So we should be careful and look at the data by ourselves and interpret it. Do not let the patient have too many unnecessary medication.
Yeah.
One of the participants curious about the pianist case. Does her vision improve at the follow-up? And is there any distinguished sign on the patient that directs this patient to conversion disorder? Maybe Professor Wang can answer.
I don't know. I don't know why her vision improved, but I know that her vision did not drop at all. Actually, in the beginning, when her vision was 660 or 630, at that time we find no evidence, no any anatomical basis for his decreased vision. So at that time in 2010, during that age, we only have the GDX without OCT. However, the GDX also measures the nerve fiber layer thickness, and her GDX analysis was totally intact. So, and from her fundus picture, we saw nothing about the optic pale or optic atrophy. We found nothing regarding that respect. So I think the decrease of vision was psychologically induced. So on the other hand, the so-called improvement is just come to the normal condition.
Okay. I think because of the time, we will have to close this discussion session. Thank you very much for Professor Wang and Dr. Alia and also the participant. This has been an interesting and useful session. To summarize, we have learned about tips and tricks to recognize the functional visual loss during our practice, and also how to make the most of our diagnostic tools to prove it. We will have 2 minutes break after this, and we will continue the second part of this webinar.
Thank you.
Oke, selamat siang. Terima kasih telah tetap bergabung dengan kita pada webinar JEC pada hari ini. First of all, I would like to apologize to Professor Wong because during the second session, we will talk in Bahasa Indonesia, but the presentation will remain written in English. And I hope that you can still join us during the question and answer session because your expertise and insights on the cases would be very useful for all of us. Untuk sesi kedua ini, judulnya adalah Avoiding Traps in Optic Nerve Problems. Kita memiliki 3 pembicara, mungkin boleh ditampilkan panitia rundown acaranya. Dimulai dari Dr. Rizky Prihatning Tias, dilanjutkan dengan Dr. Valencia, dan ditutup oleh Dr. Yunita Mansur. Oke, untuk pembicara pertama, saya ingin mengundang Dr. Rizky Prihatning Tias yang akan membawakan topik mengenai all about compressive optic neuropathy. Dr. Rizky Prihatning Tias saat ini aktif sebagai staf pengajar ilmu kesehatan mata di Universitas Diponegoro dan juga saat ini aktif sebagai dokter spesialis mata di JEC Candi, Semarang. Beliau telah menyelesaikan pendidikan fellowship neurooftalmologi di Jogja dan saat ini juga aktif pada berbagai society membership. Kepada Dr. Rizky, silahkan dok. Waktu dan tempat dipersilahkan.
Ya, terima kasih Dr. Alia. Mohon maaf ini video saya. Oh ya, oke. Ya, saya share screen dulu. Kok nggak mau ya, Mas? Mas Sony bisa share screen saya? Halo Mas Sony, bisa minta tolong? Iya. Ya, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, Profesor dan para dokter sekalian. Siang ini saya akan berbagi tentang all about compressive optic neuropathy. Slide. Ya, untuk pendahuluan sebagai definisi, compressive optic neuropathy terjadi akibat adanya kompresi mekanik oleh tumor maupun non-tumor yang bisa mengenai nervus opticus di bagian intraorbital, intrakanal maupun intrakranial. Penyebabnya bisa berupa lesi intrinsik maupun ekstrinsik. Slide. Untuk lesi intrinsik biasanya disebabkan karena optik nerve glioma, namun kasusnya jarang. Sedangkan untuk lesi yang ekstrinsik bisa disebabkan karena lesi infeksi, bisa berupa aspergilloma, inflamasi seperti pseudotumor dan Graves orbitopati, vaskular seperti aneurisma dan CCF, traumatik bisa pada pasien trauma yang mengalami retrobulbar hemorrhage, kemudian neoplastik ini yang mungkin cukup banyak, bisa karena meningioma, limfoma, pituitary adenoma, craniopharyngioma, dan mungkin lesi metastatik. Bisa juga disebabkan karena tumor pada tulang seperti pada fibrous dysplasia dan osteoma, dan bisa juga karena penyebab lain seperti mukokal. Slide. Ya, untuk epidemiologinya secara umum didapatkan 4 kasus per 100.000 orang per tahun. Untuk jenis kelamin, etnisiti, dan umur sangat bervariasi tergantung dari etiologinya. Seperti contohnya pada Graves orbitopati ini lebih banyak ditemukan pada wanita dibanding pada pria. Dan untuk penyebab paling banyak ditemukan adanya pituitary adenoma dengan prevalensi sekitar 10,5%. Slide. Ya, untuk patofisiologinya sendiri, kompresif optik neuropati ini bisa disebabkan karena kompresi pada vascular supply sehingga menyebabkan iskemik pada optic nerve. Juga adanya efek massa pada akson sehingga menyebabkan gangguan transport akson dan transmisi sinyal. Kita harus ingat juga bahwa optic nerve itu melewati suatu bagian sempit, yaitu pada orbital apex dan optic canal, sehingga ini pada pasien-pasien trauma sering terjadi kompresi akibat fraktur tulang atau karena perdarahan. Kemudian untuk penyebabnya thyroid eye disease ini bisa kompresi karena adanya pembesaran dari muskulus ekstraokuler yang bisa ditandai dengan adanya exophthalmos. Slide. Untuk mendiagnosis suatu kompresi optik neuropati, kita harus mampu melakukan anamnesis dan pemeriksaan fisik yang baik, lengkap, dan teliti. Ini ada beberapa petunjuk untuk melakukan anamnesis saat kita menemui pasien dengan suspek kompresif optik neuropati. Yang pertama untuk visusnya, penurunan visus khas pada kompresif optik neuropati bersifat kronik progresif, bisa pada satu mata maupun dua mata. Pasien bisa mengeluhkan juga nyeri kepala, nausea, vomiting, penglihatan double, diskromatopsia, exophthalmos, adanya RAPD, fotofobi, matanya merah, atau ada penurunan berat badan yang penyebabnya tidak jelas. Namun bisa juga terjadi penurunan visus yang tiba-tiba dan berlangsung cepat, misalnya pada kasus trauma. Ini ada beberapa anamnesis yang bisa dilakukan apabila kita menemui pasien kompresi optik neuropati. Slide, diklik aja Mas. Ya, ini ada grafik yang menunjukkan perbedaan antara optik neuritis, iskemik optik neuropati, dan kompresif optik neuropati. Kita lihat bahwa pada optik neuritis penurunan visusnya berlangsung secara gradual, berlangsung dalam beberapa hari yang akan kemudian membaik setelah rata-rata hari ke-6 atau ke-7. Sedangkan pada iskemik optik neuropati, visus turun mendadak, kemudian stabil pada visus terjeleknya. Sedangkan pada kasus kompresif optik neuropati, visus akan turun terus-menerus, bisa sampai mencapai NLP apabila penyebabnya tidak segera kita atasi. Slide. Ya, untuk pemeriksaan fisiknya kita harus melakukan pemeriksaan fisik yang lengkap dan teliti, mulai dari pemeriksaan visus cukup dengan Snellen chart, kemudian untuk pemeriksaan funduskopi nanti akan dijelaskan untuk optik diskapnya, tapi bisa ditemukan ada gambaran funduskopi papil nervus 2 yang normal, bisa edem atau atrofi. Kemudian untuk pemeriksaan slit lamp, jangan lupa kalau kita menemui pasien dengan injeksi konjungtiva yang berlangsung terus-menerus, sudah kita berikan bermacam-macam obat tapi ternyata tidak sembuh, jangan lupa tanyakan riwayat trauma dan sebagainya untuk menyingkirkan adanya diagnosis SLF. Kemudian untuk pupil didapatkan RAPD positif pada kasus yang unilateral atau bilateral yang asimetris. Visual field defect nanti akan dijelaskan di belakang. Terus untuk pemeriksaan isi hara, untuk melihat adanya diskromatopsia atau tidak, tonometri ini penting untuk menyingkirkan diagnosis glaukoma, atau mungkin juga memang ada peningkatan TIO sekunder karena kompresinya. Kemudian jangan lupa untuk memeriksa gerak bola mata, karena apabila didapatkan ophthalmoplegia, ini mengindikasikan bahwa tidak hanya nervus 2 yang terkena, namun bisa juga nervus 3, 4, atau 6. Dan dilihat juga pada pasien ada tidaknya proptosis. Slide. Ya, ini untuk pemeriksaan optic disc cupping, di slide aja Mas. Ya, optic disc cupping sendiri bisa terjadi karena kongenital atau acquired. Untuk kongenital ini contohnya adalah pada pasien morning glory syndrome, optic disc globoma, tilted optic disc megalopapilla, dan optic nerve hypoplasia. Slide. Sedangkan yang acquired paling sering disebabkan karena glaukoma. Tapi jangan lupa lesi-lesi neurooftalmologis karena iskemik, toksik, atau kompresif seperti yang kita bahas siang ini, dan bisa juga karena kelainan genetik. Nah, intracranial lesion ini kadang memberikan gambaran optic disc yang mirip dengan glaukoma, sehingga sering kita temui adanya misdiagnosis. Demikian juga visual field-nya kadang juga membingungkan, sehingga disebutkan bahwa mendiagnosis kompresi optik neuropati dari klasik NTG atau normotension glaukoma itu bisa menjadi hal yang sulit. Slide. Nah, kita ulang dulu untuk optic disc cupping, bagaimana yang terjadinya. Optic nerve head itu terdiri dari 3 lapisan. Yang pertama retinal nerve fiber layer, kemudian prelaminar layer yang terdiri dari lapisan nerve dan glia yang loose. Kemudian apabila terjadi kehilangan pada lapisan ini akan menyebabkan shallow cupping atau kita sebut dengan prelaminar cupping. Sedangkan lapisan ketiga yang lebih dalam lagi ini terdapat disclera portion dari lamina cribosa, dan apabila kehilangan jaringan ini, jaringannya bisa terdiri dari jaringan akson, pembuluh darah, konektif tisu maupun astrosit, itu bisa menyebabkan yang namanya deep cupping atau laminar cupping. Cupping sendiri tidak hanya disebabkan karena kehilangan akson, tapi juga supportive glial tissue. Apabila terjadi kehilangan akson yang luas, namun glial tisunya masih baik, akan didapatkan gambaran optic disc yang pucat, namun tanpa disertai dengan cupping. Slide. Ya, untuk membedakan apakah ini glaukoma atau non-glaukoma cupping, ini secara umum belum membedakan dengan yang kompresi optik neuropati. Yang pertama kita lihat visual acuity dan color vision-nya. Pada pasien glaukoma biasanya akan terjadi penurunan visus dan gangguan warna itu pada stadium yang advance. Sedangkan untuk yang optik neuropati lebih sering terjadi lebih awal. Kemudian untuk gangguan warnanya, kalau optik neuropati ini menyebabkan defisiensi red green, sedangkan glaukoma lebih sering blue yellow. Kemudian kita harus perhatikan juga pada pasien-pasien yang mempunyai gangguan color vision itu lebih berat dibandingkan dengan visual acuity atau visual field-nya, kita curigai ini suatu non-glaucomatous cupping. Neuroimaging dipertimbangkan pada pasien-pasien yang mempunyai RAPD yang cukup besar, kecuali memang tampak perbedaan yang asimetris antara kedua mata, dan sudah jelas ini defeknya adalah suatu defek glaukoma. Slide. Nah, untuk optic disc assessment sendiri, ini ada beberapa tanda yang bisa kita temui untuk membedakan apakah ini glaukoma atau non-glaukoma. Yang pertama pada glaukoma itu adanya focal loss pada neuroretinal rim, dikatakan 87% spesifik untuk glaukoma. Dan pada neuroretinal rim yang masih tersisa, warnanya masih normal. Adanya vertical cup elongation, adanya splinter hemorrhage, dan ada perubahan vaskulatur dari pembuluh darah di optic disc-nya. Sedangkan yang non-glaukoma, 94% dikatakan suatu non-glaukoma cupping apabila rim yang tersisa itu warnanya juga pucat. Ini ada satu jurnal yang menghitung secara kuantitatif perbedaan asimetri antara mata yang menderita kompresi optik neuropati, ternyata didapatkan pada yang kompresi optik neuropati asimetri kedua mata 0,13, dan ini signifikan lebih tinggi dibandingkan pada pasien kontrol di mana dapatkan asimetri 0,04. Slide. Ya, ini sebentar Mas yang tadi. Yang sebelumnya. Ya, ini ada tabel yang mengindikasikan kapan kita mempertimbangkan suatu pemeriksaan neuroimaging pada pasien-pasien dengan optic disc cupping. Definite indication-nya bisa pada pasien yang ditemukan adanya vertical align field defect, adanya pallor dari neuroretinal rim seperti tadi sudah dijelaskan, adanya disfungsi dari pituitari, dan adanya kelainan neurologis yang lain. Sedangkan untuk yang potensial indikasinya adanya RAPD, pasien kurang dari 50 tahun, asimetri color vision-nya dan visual acuity-nya kurang dari 20/40. Slide. Ya, ini salah satu contoh perbedaan cupping antara pasien glaukoma dan non-glaukoma. Yang atas itu yang glaukoma, kita lihat bahwa ada yang ditandai dengan anak panah, adanya kehilangan neuroretinal rim bagian superior, kemudian neuroretinal rim yang tersisa warnanya masih normal ya, kemudian didapatkan deep cupping dan perubahan dari posisi pembuluh darah. Ini sesuai dengan lapang pandang yang didapatkan adanya arcuata inferior sesuai dengan kehilangan neuroretinal rim bagian superior. Untuk gambar C, ini penyebabnya bukan kompresif, tapi suatu autosomal dominan optik atrofi. Kita lihat di sini bahwa neuroretinal rimnya itu tampak pucat semua, kemudian cuppingnya hanya shallow, dan tidak ada perubahan posisi dari pembuluh darah. Dan pada lapang pandang kita dapatkan adanya central scotoma. Slide. Nah, kita masih ingat ya untuk gambar lapang pandang, lesi yang terjadi di sepanjang visual pathway. Jadi ini mengulang saja, kalau misalnya kena nervus opticus bisa terjadi anopsia, kalau terjadi di bagian anterior dari chiasma opticum bisa menyebabkan gambar yang nomor 2 ini adalah suatu junctional scotoma, kemudian bitemporal hemianopia apabila ada lesi yang mengenai chiasma opticum, dan retrochiasma itu adanya defek lapang pandang yang mengikuti vertical meridian. Slide. Ya. Ini ada beberapa tanda yang bisa digunakan untuk membedakan visual field pasien glaukoma dan tidak. Yang pasien glaukoma itu biasanya ada 4 pattern mayornya ya, ada isolated scotoma, arcuate scotoma, nasal step, dan generalized depression. Pada NTG biasanya akan lebih terlokalisasi dengan arah mendekat pada fiksasinya dan biasanya terjadi pada superior hemifield. Untuk visual field defect yang tadi ya menyesuaikan dengan vertical meridian, kita harus yakinkan kalau ini memang penyebabnya bukan suatu lesi neurologi. Slide. Ya, ini ada satu jurnal, jadi ada Dr. Bolan dan kawan-kawan, dia membuat suatu algoritma mirip dengan glaukoma hemifield test. Kalau yang ini namanya neurological hemifield test. Jadi dia bisa mendeteksi visual field defect yang disebabkan karena lesi kiasma dan post kiasma. Ini seperti tabel di atas ini adalah dia menggunakan skor yang sesuai dengan pattern deviation probability. Memang mirip dengan glaukoma tapi angkanya memang agak berbeda. Kemudian pada Humphrey 24-2-nya kita gambar seperti ini. Dan itu di setiap bagian 1 dan 2 itu ada 16 titik yang nanti akan diisi skornya yang dari tabel di atas. Kemudian di total dan dari skor tersebut di selisihnya berapa. Itu yang menjadi final NHT value. Dan hasil dari jurnal ini disebutkan bahwa NHT ini secara efektif dapat membedakan lesi neurologik pada pasien yang glaukoma suspek dan pasien glaukoma, walaupun pada lesi yang masih subtle atau masih ringan. Slide. Ya, ini salah satu contoh defek lapang pandang. Di sini penyebabnya ternyata suatu neurologis dan bisa dilihat dengan NHT yang tadi. NHT juga disebutkan bisa membedakan lesi kiasma dan post kiasma, dan harapan dari peneliti ini NHT nanti bisa bisa sama dengan GHT dalam membedakan lesi pada visual field akibat neurologis atau bukan. Dan ini juga bisa memperingatkan para klinisi untuk mencari kemungkinan adakah penyakit neurologis. Slide. Ya, kemudian pemeriksaan yang kedua, selain visual field, kita juga bisa melakukan pemeriksaan OCT. Seperti tadi sudah diterangkan Dr. Alia, ini saya ada beberapa jurnal yang menyebutkan perbedaan antara yang glaukomatik optik neuropati dan non-glaukomatik optik neuropati. Yang glaukomatik optik neuropati biasanya terdapat penipisan RNFL di bagian inferior dan inferior temporal, sedangkan yang non-glaukomatik optik neuropati ada penipisan di bagian nasal. Dan apabila didapatkan CDR dan average RNFL yang similar atau sama, pada non-glaukomatik optik neuropati didapatkan ketebalan RNFL bagian nasal dan temporal yang lebih rendah, begitu juga ketebalan pada makula dan volumenya lebih rendah pada non-glaukomatik optik neuropati dibanding pada pasien glaukoma. Yang sebelah kanan ini selain pemeriksaan RNFL, harus diperiksa juga GCL-IPL, tadi sudah dicontohkan Dr. Alia. Jadi ini pasien adenoma hipofisis, terdapat penurunan dari GCL-IPL bagian temporalnya sehingga sesuai dengan bagian nasalnya sehingga sesuai dengan gambaran visual field bitemporal hemianopia. Slide. Ya, untuk pemeriksaan neuroimaging ini juga penting ya, karena memang harus mendiagnosis di mana letak kelainannya dan apa jenis kelainannya. Pemeriksaan MRI sangat penting untuk melihat area optic nerve-nya, parasellar area atau orbital content-nya, dan jangan lupa untuk sequence fat supresi. Untuk pasien-pasien aneurisma kita lanjutkan dengan pemeriksaan MRA dan ESA. Kemudian kasus yang melibatkan tulang lebih baik diperiksa dengan menggunakan CT scan. Slide. Ya, untuk manajemennya, yang tadi Mas, manajemennya tentu saja kita harus mengobati atau menata laksana dari penyakit yang mendasari. Misalnya kalau penyebabnya adalah suatu penyakit tiroid, kita bisa berikan kortikosteroid. Kemudian untuk yang SOL intrakranial, kita bisa refer ke dokter bedah saraf untuk dilakukan dekompresi atau mungkin terapi radiasi, misalnya pada pasien-pasien meningioma. Slide. Ya. Tapi selain kita hanya merefer, tapi kita juga harus memprediksi kapan pasien tersebut bisa terjadi perbaikan dari fungsi visualnya. Ternyata di sini ada beberapa faktor, yaitu apabila didapatkan pasien dengan visus penurunannya tidak begitu berat, tidak ada optik atrofi, tumor size-nya itu kecil, kemudian reseksi dari tumor primer dan bukan suatu tumor yang residif, tidak ada keterlibatan sinus cavernosus, konsistensi tumor yang lunak, kemudian masih adanya arachnoid plane dan reseksi yang ekstensif, dikatakan pasien tersebut akan mengalami improvement dari visual function-nya. Sedangkan untuk umur dan gender tidak signifikan. Slide. Ya, ini lanjut ke kasus. Pasien umur 33 tahun di-refer dengan penurunan visus progresif selama 3 tahun ini. Pasien awalnya didiagnosis dengan glaukoma dan menjalani terapi glaukoma topikal. Mata kirinya kemudian ikut buram 1 tahun ini tanpa disertai dengan nyeri kepala, nausea, vomit, dan kelainan yang lain. Ini pemeriksaan oftalmologisnya, visus NLP, yang kanan ya TIO normal, isi hara dan kontras tidak bisa dinilai, sedangkan mata kiri visus masih relatif baik, 6/30, TIO-nya 18, pupil normal, isi haranya terjadi penurunan 32/38 plate, dan penurunan kontras 10%. Slide. Ya, klik-klik aja Mas. Ya, ini gambar fundus, lapang pandang, OCT RNFL, dan OCT GCL-IPL. Slide. Ya, silakan untuk polling untuk pertanyaannya. Apakah etiologi dari optik atrofi pada pasien ini? Yang pertama, apakah suatu glaukomatus optik neuropati atau non-glaukomatus optik neuropati? Saya kira cukup hasilnya. Bisa diperlihatkan hasilnya, Mas Sony? Oh.
Sudah dok, silakan.
Belum tampak ya? Bentar. Ya, sebagian besar menjawab non-glaukomatus optik neuropati. Oke, polling kedua bisa dilanjutkan. Ya, oke, ya, semuanya sudah benar ya dalam menjawabnya. Mas Sony bisa kembali ke gambar yang tadi, yang sebelum polling pertama ya. Ini kita lihat ya bahwa pada mata kanan neuroretina rimnya semuanya sudah pucat dan sekilas malah tidak tampak gambaran cupping ya. Dan pada pemeriksaan lapang pandangnya, ini didapatkan hemianopi temporal pada mata kiri karena mata kanannya tidak bisa dilakukan pemeriksaan. RNFL-nya tipis terutama pada mata kanan, dan kita lihat tadi pada GCL-IPL-nya terdapat penipisan pada bagian nasalnya. Slide ke yang berikutnya, ya. Kemudian tadi untuk pemeriksaan selanjutnya dilakukan MRI pada pasien ini dan ternyata memang didapatkan suatu gambaran pituitari adenoma. Slide, diklik. Kami merefer pasien tersebut ke bedah saraf, namun sayang 2 tahun kemudian terjadi residif dari pasien tersebut. Untuk kesimpulannya, membedakan NTG dan penyakit neurooftalmologis kadang sulit, sehingga ada beberapa catatan yang bisa dilakukan untuk membedakan apakah ini pasien glaukoma atau suatu neurooftalmologis. Yang pertama, apabila didapatkan disproporsi dari color vision loss dibandingkan dengan visual acuity-nya, visual field defect-nya yang tidak sesuai dengan perubahan pada optic disc, kemudian ada vertically aligned visual field defect, adanya pakai RAPD, dan tadi retinal rim yang pucat. Kita harus ingat bahwa mendiagnosis apabila terjadi kesalahan tidak hanya merugikan secara klinis seperti mendelay pasien ini untuk dilakukan penata laksanaan di bedah saraf, tapi juga secara ekonomi karena pasien juga akan mendapatkan pengobatan yang sebenarnya tidak diperlukan oleh pasien tersebut. Ya, slide. Ya, terima kasih atas perhatiannya. Saya kembalikan ke Dr. Alia.
Terima kasih Dr. Rizky untuk presentasinya yang sangat menarik dan sangat penting tentunya ya untuk membedakan kompresi dengan lesi non-kompresi. Untuk sesi berikutnya, saya ingin mengingatkan kepada para peserta boleh juga mencantumkan pertanyaannya pada kolom tanya jawab di bagian bawah dari Zoom-nya yang akan kita bahas di akhir sesi ini. Untuk berikutnya saya mengundang Dr. Valencia untuk topik kedua dengan judul Idiopathic Intracranial Hypertension Not So Benign After All. Dr. Valencia telah menjalani beberapa fellowship di luar negeri, neurooftalmologi di Prancis, dan saat ini aktif sebagai dokter spesialis mata di Neuroophthalmology Service JEC Eye Hospitals and Clinics. Kepada Dr. Valencia, silahkan untuk presentasinya, 15 menit ya dok.
Ya, terima kasih Dr. Alia atas perkenalannya. Apakah slide saya terlihat?
Ya, sudah terlihat, Dok.
Ya. Selamat siang dan salam sejahtera untuk para profesor dan dokter yang saya hormati. Semoga kita semua berada dalam kondisi sehat. Pada siang hari ini saya akan bawakan topik berjudul Idiopathic Intracranial Hypertension Not So Benign After All. And I'm going to apologize first to Professor Wang because I will deliver the topic in Bahasa. But my slide and the case illustration will be in English. So I hope later you can join in the discussion. Saya tidak memiliki kepentingan finansial. Definisi dari intracranial hypertension adalah peningkatan tekanan intracranial di atas 25 cm air tanpa adanya tanda dari kelainan patologis otak yang mendasari seperti massa atau kelainan malformasi, ataupun kelainan abnormal dari enhancement dari meninges atau komposisi dari cerebrospinal fluid. Nah, kata-kata without ini saya garis bawahi karena artinya kita harus mencari dahulu kelainan yang dapat mendasari peningkatan tekanan intracranial sebelum kita mendiagnosis pasien dengan IIH, sehingga sifatnya adalah diagnosis eksklusi. Terminologi lain yang dapat digunakan adalah pseudotumor cerebri, yang sifatnya lebih luas, karena pseudotumor cerebri yang primer itu adalah yang IIH, sedangkan yang secondary dapat terjadi akibat adanya riwayat pengobatan, kelainan hormonal, dan kelainan sistem venosus otak. Sedangkan terminologi benign intracranial hypertension tidak lagi digunakan. Mengapa? Karena peningkatan tekanan intracranial dapat diteruskan ke jaringan fluid antar akson, sehingga nervus opticus mengalami kondisi stasis aksoplasmik dan kita lihat sebagai kondisi papil edema. Bila hal ini tidak ditangani dengan baik, akan berlanjut menjadi papil atrofi dan menyebabkan visual loss yang sifatnya signifikan dan permanen. Hal ini terjadi pada 25% kasus. Sehingga kegagalan untuk mengidentifikasi pasien-pasien ini di awal akan menyebabkan pasien berisiko kebutaan yang sebenarnya dapat dicegah. Insidensinya sendiri mencapai 0,9 sampai 1,7 per 100.000, meningkat pada wanita di usia reproduktif, dan meningkat lebih tinggi lagi di wanita yang mengalami obesiti. Bagaimana hal ini bisa terjadi? Hingga saat ini banyak hipotesis dan semuanya terletak pada ketidakseimbangan antara peningkatan produksi dari CSF dengan penurunan drainase dari CSF akibat obstruksi outflow atau peningkatan tekanan sinus venosus. Kita tahu sebagian besar CSF ini diproduksi di sel epitel plexus choroid dan sebagian kecil di sel ependimal yang melapisi ruang ventrikular. Sedangkan drainase utamanya adalah lewat granulasi arachnoid ke sinus sagittal superior. Drainase lainnya adalah melewati cribriform plate yang terletak di sepanjang nervus cranial ke lymphatic pathway dan lymphatic pathway. Kita tahu bahwa kejadian IIH ini predileksinya pada wanita, sehingga ada hipotesis endokrin yang mendasarinya, karena ditemukan banyak reseptor mineralokortikoid di sel epitel plexus choroid. Begitu juga kita tahu peningkatan tekanan intraabdomen sekunder karena obesitas dapat meningkatkan tekanan pleura dan cardiac filling yang menyebabkan peningkatan tekanan venosus intrakranial dan berakibat pada peningkatan tekanan intrakranial. Bagaimana gejala yang dikeluhkan pasien? Pasien biasanya mengeluh sakit kepala yang sifatnya pulsatil dan diperberat dengan gerakan-gerakan yang meningkatkan tekanan intrakranial seperti mengedam atau membungkuk atau berbaring. Dan biasanya pasien datang ke kita tentu dengan gejala visual. Pasien biasanya mengeluh transient visual obscuration yang hilang timbul, biasanya juga dipengaruhi oleh gerakan tubuh pasien, dan kadang-kadang juga disertai dengan diplopia yang binokular. Nah, lebih dari 70% kasus IIH ini mengeluh visual loss, sehingga sangat mungkin dokter mata adalah dokter yang pertama menemukan pasien IIH. Nah, gejala awalnya belum tentu penurunan visus, bisa juga gangguan lapang pandang ataupun distromatopsia atau gangguan fungsi warna. Gejala lain yang perlu kita tanyakan, apakah ada tinnitus, nyeri di punggung, leher, pusing, mual, penurunan kognitif, ataupun nyeri di sendi. Bagaimana tanda yang kita akan temukan? Seluruh pasien akan datang dengan papil edema, namun gradingnya bisa berbeda-beda. Ini adalah grading yang dapat kita temukan, Friesen-nya dari grading 1 hingga grading 5. Sedikit mengenai grading dari papil edema. Bila blurred disc margin-nya belum keseluruhan, bentuknya C-shape dan temporalnya masih baik, ini disebut grade 1. Namun bila halonya sudah sirkumferensial disebut grade 2. Dan bila sudah mulai ada pembuluh darah yang terobscuration ketika keluar dari optic nerve, ini disebut grade 3. Dan bila pembuluh darah yang ada di optic nerve dan keluar dari optic nerve mengalami obscuration disebut grade 4. Dan bila keseluruhan pembuluh darah mengalami obscuration disebut grade 5. Mendiagnosis grade 3, grade 4, grade 5 mungkin mudah dengan pemeriksaan klinis, namun kadang-kadang pada kasus papil edema yang ringan, grade 1, kita memerlukan pemeriksaan OCT disc untuk mengkuantifikasi dan mengkonfirmasi apakah ada disc swelling atau tidak dengan analisis RNFL. Sedangkan analisis dengan ketebalan sel ganglion akan mendeteksi neuron loss di awal dan apakah menentukan apakah pasien ini membutuhkan treatment yang agresif atau tidak. Ini adalah contoh penggunaan OCT optic disc dan ganglion untuk prediktor prognosis IIH. Ada dua kasus A, kasus B. Di awal kasusnya kondisinya dua-duanya papil edema yang dikonfirmasi dengan peningkatan ketebalan RNFL. Namun perhatikan ketebalan sel ganglion di kasus A masih baik, sedangkan di kasus B sudah terjadi penurunan. Pada perjalanannya kedua pasien ini mengalami remisi papil edemanya. Namun di kasus yang A, ketika ketebalan sel ganglion masih baik, maka visual field-nya jadi baik, hanya enlarged blind spot. Sedangkan pada kasus yang B, karena sudah terjadi penipisan dari sel ganglion, walaupun ketebalan RNFL di awal tinggi, maka visual field defect-nya akan tetap ada. Selain penggunaan analisis RNFL, kita juga bisa menggunakan Enhanced Deep Imaging OCT untuk monitor dari treatment. Ini adalah A, sebelum vipisan, dan yang ini yang B setelah treatment vipisan. Yang perlu kita perhatikan adalah angle dari membrana Bru dengan vitreous. Bila bentuknya seperti ini naik, berarti papil edema masih terjadi. Manifestasi klinis yang bisa kita lihat adalah sixth nerve palsy. Perhatikan ada limited dari abduction di mata sebelah kiri. Ini dikonsider sebagai false localizing sign berhubungan dengan peningkatan tekanan intrakranial. Ini adalah diagnosis langkah diagnostik untuk kasus IIH. Bila kita menemukan pasien dengan gejala IIH dan papil edema, maka kita perlu lakukan pemeriksaan visual acuity, pemeriksaan pupil, pemeriksaan tekanan bola mata karena hipotoni kadang-kadang bisa menyebabkan disc swelling. Visual field biasanya kita temukan adalah enlarged blind spot atau localized visual defect. Dan jangan lupa lakukan pemeriksaan fundus dengan midriatil untuk melihat derajat dari keparahan papiloedemanya dan untuk mengeksklud apakah ada ocular cause dari yang menyebabkan papiloedema. Dan juga kita perlu lakukan OCT papillary ganglion bila ada. Jangan lupa lakukan pemeriksaan tekanan darah untuk mengeksklusi hipertensi maligna. Bila tidak ada, idealnya kita minta pasien untuk MRI dan MRV kurang dari 24 jam. Dan bila tidak ada massa, tidak ada kelainan anatomis, maka kita dapat lanjutkan untuk pemeriksaan lumbar puncture untuk menentukan apakah opening pressure-nya tinggi atau tidak. Dan juga untuk mengirim CSF-nya untuk dianalisis. Bila semuanya normal, maka ini semakin menguatkan ke arah IIH. Perlu kita exclude penyebab-penyebab sekunder yang dapat menyebabkan peningkatan tekanan intracranial, seperti yang sering anemia, kita lakukan pemeriksaan lab, lalu MRV yang tadi di sini juga dapat menentukan apakah pasien memiliki cerebral venous sinus thrombosis. Dan jangan lupa lakukan anamnesis yang mendetail mengenai riwayat pengobatan yang dimiliki pasien, yang biasanya sering di wanita usia reproduktif adalah pengobatan untuk jerawat, yaitu vitamin A, derivat, dan tetrasiklik. Juga kita perlu lakukan konsultasi ke dokter endokrinologis untuk menyingkirkan kelainan sistemik dan endokrin. Bila semuanya tidak ada, maka semakin menegakkan diagnosis IIH. Kita tanyakan apakah ini vision threatening, bila iya, maka disebut IIH fulminant. Apakah ini wanita usia reproduksi dengan obesitas? Bila iya, ini tipikal. Bila tidak, ini atipikal dan kita perlu cek lagi di tabel ini apakah ada yang miss oleh kita. Setelah ini saya akan tampilkan 2 jenis kasus. Mohon diperhatikan karena ada pertanyaan setelahnya. Kasus pertama laki-laki 52 tahun dengan papiloedema, enlarged blind spot, visual acuity 1,0 dan sakit kepala. Pasien ini setelah dilakukan MRI hasilnya normal. Cuma pasien lost to follow up dan 1 tahun kemudian dia datang lagi dengan kondisi papiloedema yang semakin berat dan juga visus yang menurun dan gangguan visual field defect yang semakin besar. Ini kasus pertama, bandingkan dengan kasus kedua, wanita usia 26 tahun dengan obesitas, mengeluh sakit kepala dan datang dengan gambaran papiloedema, enlarged blind spot, visus 0,09. Pasien dilakukan MRI, MRV, hasilnya tidak ada venous thrombosis, tidak ada kelainan intracranial. Pasien ditreatment dengan acetazolamid dan 11 bulan kemudian papiloedemanya resolve, sudah mengalami remisi, visusnya juga stabil dan visual field defect-nya, pembesaran blind spot-nya sudah perbaikan. Nah, dokter sekalian bisa mengisi mana dari 2 kasus di atas yang cocok disebut fulminant IIH, apa kasus pertama yang laki-laki itu atau yang kedua. Oke, bisa ditampilkan hasilnya? Masih 50-50 ya. Ya, jadi memang kasus pertama yang disebut dengan fulminant IIH. Kenapa? Karena mengalami vision threatening. Pentingnya apa? Kita menentukan ini IIH-nya fulminant atau tidak, karena approach terapinya akan berbeda. Nah, terapi ini goal-nya adalah untuk treat underlying disease-nya, dan untuk protect penglihatannya, dan meminimalkan sakit kepalanya. Nah, biasanya semua pasien akan kita anjurkan untuk turunkan berat badan hingga 15% dan diet rendah garam. Juga dapat diberikan acetazolamid dimulai dari 2 kali 500 mg, dititrasi maksimum 4 gram per hari. Perlu kita perhatikan efek samping acetazolamid diinformasikan ke pasien seperti metallic taste, kesemutan, dan bila pasien tidak bisa toleransi dapat diganti dengan furosemid 20-40 mg per hari. Topi ramat juga dapat digunakan karena dapat mensupres selera makan. Namun perlu diperhatikan karena populasi wanita di usia reproduktif, topi ramat ini merendahkan kemampuan dari kontrasepsi hormonal. Nah, dan juga memiliki efek samping teratogenik. Nah, surgical treatment yang dapat pilihan yang dapat dikerjakan adalah optic nerve sheath fenestration atau VP sham. Tergantung mana yang lebih berat. Bila visual loss-nya lebih berat, maka dipilih ONSF. Bila headache-nya yang lebih berat, maka VP sham. Dan beberapa treatment baru seperti endovascular stent sedang dalam research. Lumbar puncture yang serial juga sifatnya kontrafleksi karena kita tahu CSF itu diproduksi secara reguler sehingga dalam waktu 2 jam sirkulasinya akan full lagi. Biasanya pasien tapi akan mengalami perbaikan setelah 1 kali LP yang dihipotesiskan terjadi karena adanya leak dari lokasi LP-nya sendiri, atau ketika dilakukan lembal puncture itu ada dekompresi pada villi arachnoid sehingga memperbaiki absorpsi dari CSF. Rekomendasi treatment yang dianjurkan untuk dokter mata adalah apakah ada visual loss atau tidak. Bila tidak ada, weight loss dan low natrium diet cukup. Bila ada, misalnya visusnya lebih baik daripada 20/30 dengan hanya gangguan enlarged blind spot, maka dapat kita tambahkan acetazolamid dan topiramat serta observasi yang agresif. Namun bila fulminant IH, maka kita perlu konsulkan pasien ini untuk ONSF atau CSF diversion. Dan ini sifatnya bisa naik turun, rekomendasi treatmentnya tergantung dari follow up. Prognosis secara umum baik dan kebanyakan pasien kondisinya self-limited, remisi akan terjadi dalam 1 tahun, namun akan ada 25% pasien yang akan mengalami permanen visual loss, sehingga kata-kata benign tidak lagi kita gunakan. Dan 10% pasien dapat mengalami rekurensi setelah remisi, dan untuk sebagian kecil pasien perjalanan penyakitnya kronik. Follow up sendiri dilakukan berdasarkan grading papilledema dan fungsi dari visual. Ini case terakhir, perempuan 26 tahun dengan nyeri kepala hebat dan progressive blurred vision sejak 2 bulan. Pasien juga memiliki irregular menstrual cycle dan dia memiliki nystagmus yang dialami sejak kecil. Berat badannya 84, tinggi 165 dan BMI-nya obesitas. Tekanan darahnya baik, 130/80. Ini adalah gambaran nystagmusnya. Nystagmusnya kongenital karena horizontal ke semua posisi dan ada null positionnya. Nah, pada pasien ini visus yang kanan 0,1 tata koreksi, yang kiri 0,16, tekanan agak naik sedikit, isi hariannya kurang baik, konfrontasi di seluruh kuadran counting finger, RAPD negatif, segmen anterior normal, nah sedangkan segmen posteriornya ditemukan papilledema. Ini adalah gambaran optic nerve OCT-nya, ketebalan RNFL-nya mengkonfirmasi papilledema, cuma hanya ketebalan sel gangliannya sudah rendah. Humphrey tidak dapat dilakukan karena pasien nystagmus dan fiksasinya kurang baik. Nah, dengan working diagnosis papilledema, ocular hypertension, dan congenital nystagmus, apa step berikutnya yang dapat dipilih oleh para dokter? Silakan dipilih di Zoom polling-nya. Apakah A, merefer pasien untuk lembal puncture, B, brain CT scan dengan kontras, C, kontras brain dengan MRI MRV, atau yang keempat, refer pasien untuk possible intracranial mass. Bisa ditampilkan, Mas, hasilnya? Ya, baik sekali. Banyak yang menjawab tepat MRI dan MRV. Ini adalah gambaran MRI dari pasien. Perhatikan ini gambaran khas bila terjadi peningkatan tekanan intrakranial bahwa ada flattening dari globe dan tertos dari optic nerve. Dan ini juga gambaran khas yaitu sela yang kosong. MRV-nya sendiri tidak ditemukan trombus atau venous infarct, namun ditemukan narrowing dari sinus transversus venous transversus kanan dan kiri. Hasil labnya masih dalam batas normal, fungsi tiroidnya normal, trombosit agregasinya juga normal. Sehingga diagnosis kerja kita adalah IH dengan congenital nystagmus. Kita mulai pengobatan dengan weight loss dan natrium diet, dikonsultasikan ke dokter nutrisi, diberikan acetazolamid, suplemen kalium, dan dikonsulkan untuk lembal puncture, kemungkinan shunt, serta endokrinologis. Gambaran dari lembal puncture-nya adalah opening pressure-nya tinggi, di atas 25, yaitu 40, namun CSF analisisnya baik. Pasien menolak untuk VP shunt, diberikan edoxaban 1x30. Dari endokrinologis setelah di-exclude Cushing syndrome, dan untuk meng-exclude trombosis dilakukan DSA oleh interventional radiologis. Ini gambarannya. Ada delay dari filling transversus sinus dan right sigmoid, namun tidak ditemukan malformasi, fistule, tumor, atau ekstravasasi kontras. Pada follow-up terakhir, sakit kepalanya sudah cukup baik, perbaikan, visusnya juga sedikit naik, pasien juga telah turun berat badan 10%, acetazolamid diberikan saat ini 4x500 dan suplemen kalium 3x300 dan timol. Papilledemanya juga yang sebelah kiri sudah lebih baik, cuman yang kanan masih ada grade 2. Nah, ini karena diberikan long term acetazolamid, kita juga lakukan pemeriksaan lab rutin, fungsi ginjal, fungsi elektrolit, dan fungsi hati. Sebagai summary notes dari presentasi saya, IH seperti yang kita tahu adalah diagnosis eksklusi, maka kita lakukan workup yang dapat kita kerjakan untuk mengetahui apakah ada peningkatan tekanan intrakranial atau tidak. Dan tidak semua IH itu sifatnya benign, ada 25% kasus yang bisa mengalami progression dan visual loss, dan lakukan MRI, MRV brain untuk semua kecurigaan IH. Tentunya kita membutuhkan manajemen yang kolaboratif dengan berbagai dokter nutrisi, dokter endokrin, neuroradiologis, dan neurosurgeon. Sekian yang dapat saya sampaikan. Terima kasih untuk kesempatannya.
Terima kasih banyak Dr. Valencia atas presentasinya yang sangat menarik mengenai IIH not so benign after all. Jadi memang kita harus lebih hati-hati ya untuk ke depannya. Untuk topik terakhir, saya ingin mengundang Dr. Yunita Mansur untuk membawakan presentasi dengan judul Optic Neuritis, Recognizing the Atypical Signs to Avoid Future Problems. Dr. Yunita merupakan staf pengajar di Universitas Hasanuddin, Makassar. Beliau telah menjalani berbagai fellowship di dalam dan di luar negeri di bidang neurooftalmologi terutama, dan juga aktif di berbagai society di Indonesia dan di Asia. Dr. Yunita saat ini bekerja sebagai neurooftalmologis di JEC Eye Hospital and Clinic JEC Orbita, Makassar. Kepada Dr. Yunita, silakan dok.
Terima kasih Dr. Alia atas perkenalannya. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore para teman sejawat, dokter, profesor sekalian. Saat ini saya akan men-share screen materi saya, yaitu Optic Neuritis, Recognizing Atypical Signs to Avoid Future Problems. Ini bisa kelihatan ya?
Ya, terlihat dok.
Terima kasih. Nah, untuk optic neuritis, saya rasa hal ini sudah sangat sering ya kita temui, baik mungkin pada saat pendidikan untuk para dokter mata maupun pada saat sudah menjadi spesialis. Jadi, optic neuritis adalah suatu kelainan di nervus optik di mana terjadi inflamasi yang bisa menyerang atau mempengaruhi satu mata maupun kedua-duanya pada satu individu. Nah, seperti yang kita ketahui, optic neuritis dibagi dua, yaitu yang tipikal dan atipikal. Dari katanya sendiri, tipikal artinya memiliki suatu kekhususan atau khas, dan biasanya disebabkan atau berhubungan dengan multiple sclerosis. Jadi, lebih banyak sifatnya itu disebabkan oleh idiopatik. Nah, kalau atipikal sendiri, dari kata atipikal, artinya ini tidak ada kekhususan untuk setiap cirinya pada satu orang maupun orang lain dengan kegangguan yang sama bisa memperlihatkan kelainan atau manifestasi klinis yang berbeda. Makanya disebut dengan term atipikal. Jadi pada diskusi sesi ini kita akan lebih banyak membahas atipikal karena banyak hal yang bisa menyebabkan kita bisa terjerumus bila tidak bisa membedakan antara atipikal maupun tipikal optic neuritis. Untuk secara garis besarnya, kalau tipikal optic neuritis biasanya mempengaruhi hanya satu mata, di mana predileksi perempuan lebih banyak dan kadang-kadang disertai nyeri, terutama pada saat pergerakan bola mata. Rata-rata onsetnya pada usia yang cukup muda, 32-an tahun. Kemudian kalau kita lakukan fenoskopi, didapatkan normal optic disc pada 2/3 kasus, namun bisa juga kita dapatkan optic disc edema atau gambaran papil yang kabur pinggirannya atau batas kabur pada 1/3 kasus. Pada optic neuritis yang tipikal, biasanya ada improvement atau peningkatan dari gejalanya, terutama visusnya, dalam 1 bulan sejak onset. Dan biasanya ditemukan diskromatopsia yang mungkin lebih buruk dibandingkan dengan visual acuity-nya. Dan kalau kita lakukan radiographic neuroimaging, biasanya kelihatan ada enhancement atau penyangatan pada anterior optic nerve-nya. Jadi biasanya lebih kita diagnosis dengan tipikal. Pada kasus-kasus tipikal, saya rasa sudah diketahui bahwa terapinya adalah dengan optic neuritis treatment trial, yaitu 1 mg 1 gram steroid dalam hal ini methylprednisolone per 24 jam selama 3 hari, dilanjutkan 1 mg per kilogram berat badan selama 11 hari. Itu sudah di luar kepala ya. Nah, sekarang yang atipikal berbeda dengan ciri-ciri yang tipikal. Di atipikal ini biasanya bisa menyerang kedua mata, predileksi laki-laki lebih banyak menderita dibanding perempuan, dan tidak ditemukan rasa nyeri. Onsetnya pun bisa pada usia yang lebih muda ataupun yang lebih tua, dan dapat kita lihat pada pemeriksaan fundusnya bahwa tampak edema dan kadang disertai dengan vitritis. Visusnya bisa turun di atas 2 minggu dari onset dan akan terus menurun, bahkan pada saat datang pertama pun visusnya lebih jelek, yaitu mungkin 20/200 atau lebih kurang dari tersebut. Kemudian neuroimagingnya kita tampak di sini bahwa enhancement atau penyangatan bisa meluas sampai ke lebih dari setengah optic nerve di posterior sampai ke kiasma, maupun bisa memperlihatkan enhancement pada optic nerve sheath-nya. Jadi akan terlihat sangat hebat enhancement-nya. Nah, kenapa ini mesti red flag untuk atypical optic neuritis? Karena biasanya kalau pada pasien-pasien dengan atipikal, kadang-kadang pengobatannya gejalanya akan lebih buruk dan pengobatannya pun jauh berbeda dengan daripada yang tipikal, sehingga kita tidak boleh menunda-nunda maupun salah diagnosis ya. Kalau kita mendapatkan pasien dengan curiga atipikal, kita lihat dulu apakah terdapat keterlibatan kedua mata secara simultan atau beberapa waktu setelah mata sebelahnya terjadi optic neuritis. Kemudian kita lihat apakah terdapat uveitis ataupun kelainan pada retina yang dilihat dari funduskopinya. Kemudian apakah terdapat gejala-gejala non-neurological, dan biasanya juga pasien tersebut memang sedang mengalami infeksi secara sistemik. Dan yang saya garis bawahi di sini adalah neuromyelitis optica atau biasa kita sebut dengan Devic disease, karena manifestasi klinisnya yang cukup berat dan sangat mengancam visual acuity-nya. Nah, untuk NMO yang kita singkat dari neuromyelitis optica, jadi terdapat peradangan pada central nervous system, di mana pada pasien tersebut positif kita temukan serum aquaporin 4-nya atau AQP4 yang menyebabkan kelainan tersebut. Karakteristiknya perlu kita ketahui yang di sini tampak ada 6 core karakteristik. Jadi untuk menegakkan diagnosisnya harus kita mencari pada core karakteristik ini, yaitu pertama kita dapatkan optic neuritis, kemudian terdapat acute myelitis, dan yang ketiga ada area postrema syndrome. Ini adalah area di mana yang mengatur rasa mual, kemudian cegukan maupun rasa muntah yang di otak, di mana pada daerah tersebut memang tinggi aquaporin 4 kadarnya. Jadi kalau ada pasien-pasien yang dengan unexplained cegukan yang tidak dapat dia jelaskan penyebabnya ataupun rasa mual dan muntah, mungkin kita bisa menyebutkan bahwa terdapat sindrom postremanya. Kemudian ada acute brainstem syndrome dan symptomatic narcolepsy atau yang biasa disebut acute densicephalic clinical syndrome. Kemudian selain itu ada juga cerebral syndrome, di mana ada tipikal lesi-lesi di otak yang kita dapat lihat dari pemeriksaan neuroimaging. Dari ke-6 diagnosis core karakteristik ini, bila ada satu yang positif, kita anggap kita bisa mendiagnosis suatu neuromyelitis optica. atau pada pasien dengan yang dites dengan serum aquaporin 4-nya positif, dan setelah kita mengeksklusi diagnosis yang lainnya. Nah, di sini tampak kalau pemeriksaan neuroimaging bagaimana suatu atypical optic neuritis, di mana enhancement atau penyengatan yang lebih panjang, lebih ke posterior, apalagi pada kasus yang sebelahnya sudah sampai ke kiasma. Jadi ini akan mengarahkan diagnosis kita kepada suatu optic neuritis yang atipikal. Dan untuk NMO sendiri, biasanya kita lihat ada yang disebut longitudinal extensive transfer myelitis, di mana terdapat kelainan atau pola ya pada tulang belakang, dan biasanya meluas sampai lebih dari 3 ruas tulang belakang, lesi-lesi hipodens tersebut yang akan mendukung diagnosis kita menjadi suatu NMO. Bila pada pasien yang kita periksakan serum aquaporin 4-nya negatif, alternatif diagnosis itu tetap harus dieksklusi. Pasien dapat didiagnosis dengan seronegatif NMO, dan apalagi kalau terdapat 2 dari karakteristik core yang tadi. Bila terdapat radiographic pattern atau pola neuroimaging yang sesuai, kita juga bisa tetap mendiagnosis NMO pada pasien-pasien yang seronegatif. Tapi tetap disarankan untuk mengulang pemeriksaan serumnya setidaknya 3-6 bulan kemudian. Dan ingat bahwa NMO juga bisa timbul pada pasien-pasien dengan kelainan autoimun maupun dengan kelainan paraneoplastik. Penanganannya tergantung dari akut maupun kronisnya. Pada fase akut bisa kita tetap memberikan 1 gram metilprednisolon intravena selama 5 hari. Kemudian bisa juga second line-nya adalah plasma exchange. Untuk kasus-kasus kronik, obat-obat seperti azathioprine dan rituximab merupakan first line terapinya, dan second line adalah mycophenolate mofetil, methotrexate, dan mitosantron. Beberapa obat-obat lain tetapi belum lulus FDA yang masih dalam clinical trial juga banyak yang diajukan untuk pengobatan NMOSD, terutama juga pada aquaporumab ini yang memang sangat spesifik untuk aquaporin antibody. Dan pengobatan untuk multiple sclerosis seperti interferon beta, natalizumab, dan fingolimab ini malah akan mengeksaserbasi atau memperburuk suatu keadaan NMO, sehingga sangat diperlukan diagnosis yang tepat dan lebih awal untuk pasien NMO. Jangan sampai kita mendiagnosisnya dengan suatu keadaan optic neuritis yang berhubungan dengan multiple sclerosis. Jenis lain untuk atipikal mungkin saya singgung sedikit, yaitu myelin oligodendrosit glycoprotein antibody atau MOG-IG untuk optic neuritis. Biasanya didapatkan pada pasien-pasien dengan optic neuritis yang kita susah membedakannya baik dengan NMO juga. Dan biasanya pasien datang ini bisa juga disertai dengan transfer myelitis dan encephalitis. Bagaimana kita tahu ini suatu MOG optic neuritis? Biasanya kalau pasien datang ada rekurensi atau optic neuritis berulang dan didapatkan juga pada kasus yang bilateral. Kemudian didapatkan severe dysedema dan didapatkan juga ada flame shape hemorrhage biasa pada peripapilnya. Dan pada kasus-kasus ini sangat berespon dengan steroid. Ya, kadang-kadang kita juga bisa menghubungkannya dengan suatu cryon atau chronic recurrence optic neuritis. Dan memang pada pasien dengan MOG optic neuritis atau visusnya sangat buruk pada awalnya, namun lebih bagus prognosis untuk perbaikannya di kemudian hari. Dan beberapa optik neuritis yang atipikal lainnya seperti inflammatory, infectious, maupun perineuritis, ini juga penting kita ketahui perbedaan-perbedaannya sehingga dapat kita bedakan, dan untuk penanganannya tetap dianjurkan sesuai dengan penyakit atau kondisi sistemik dari pasiennya. Sebagai konklusi, tampilan atau pasien-pasien dengan atipikal optic neuritis, di mana pemeriksaan neuroimaging maupun clinical course-nya itu memang harus dapat dibedakan untuk setiap dokter, karena pada beberapa yang atipikal memang harus diberikan terapi imunosupresan lebih awal untuk menghindarkan suatu disabilitas yang lebih jangka panjang. Dan untuk melihat perbedaan-perbedaan tersebut, harus kita tahu juga bagaimana pemeriksaan maupun evaluasi neuroimagingnya sehingga kita bisa mendiagnosis lebih tepat. Terima kasih, semoga bermanfaat. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak, Dr. Yunita. So we've now come to the question and answer session. So perhaps I would like to invite also Professor Anwar Wang to make a comment on the several questions listed. So untuk yang pertama, mungkin I would like to invite Dr. Valencia first for a question addressed to her. So I saw that there is some questions that are questioning the duration of the medication of acetazolamide in idiopathic intracranial hypertension cases. So probably Dr. Valencia can address to that, and if Professor Wang has any experience on a prolonged duration of acetazolamide in these cases, what is the longest duration of idiopathic intracranial hypertension that you have to put on acetazolamide? So please, Dr. Valencia, and then Professor Wang.
Thank you for the question. Usually we give acetazolamide in EEH patient, IIA patient with mild to moderate visual loss, like enlarged blind spot or localized visual field defect, or maybe a decrease of visual acuity to 20/30 or better. But if it's more severe than that, then we do not suggest acetazolamide anymore, or we move on to the surgical treatment for the patient. And for the mild to moderate visual loss for IIH patient, we can give acetazolamide for as long as it takes until the remission of papilledema occurred, as long as we follow up the function of the renal function and also the liver function and also the electrolyte imbalance for this patient. And also we have to ask the patient whether they tolerate the side effect of the acetazolamide. As we know, acetazolamide, even only in 2 times 500 milligram per day, can produce a paresthesia and also a metallic taste, nausea, vomiting. And if they cannot tolerate to the side effect, we can try to use furosemide also, 20 to 40 milligram per day, to compensate the acetazolamide effect. Maybe Professor Wang can give comment about this. I think you're still in mute.
Oh yeah, Prof. Wang, you're still muted.
I think in Taiwan we do not have much case of the IH, and I was wondering if that's I don't know, there may be some racial differences, and however in our practice I think the acetazolamide was originally an antihypertensive drug, so it could be used for long term, and as long as you keep an eye on the electrolyte imbalance and keep on giving the patient some slow K and to supplement the potassium, and so that he won't have a electrolyte imbalance. And however, in the topic of the so-called fulminant or the malignant IIH, and there's a rapid progression of the visual loss. So we can't wait until you are doing that. So in that kind of condition, I would suggest for rapid control for the ICP, and either by lumbar puncture, and if the condition recur very fast, and you can consider to go on for the optic nerve sheath fenestration. That would be helpful for the vision recovery. I think that would be most important issue during attack of the fulminant IIH.
Yeah, thank you, Professor Wang, for your insight. Yeah, I think acetazolamide can be used for quite a long period of time, because as we all might know from the idiopathic intracranial hypertension trial, the IIHT study, I think at least they were given the acetazolamide on a tapering up dosage for 6 months, and then maintain the maximum tolerable dosage until the papillary edema and the headache subsided. So I think you can use it for quite a long time. So the second question is still addressed to Dr. Valencia, but I'm going to compress it to one question. So it's about the condition of papillary edema in pregnant patients. So what would you suggest we should do for this kind of patient? Is it actually an idiopathic intracranial hypertension, or could it be associated with something else? And what should be confirmed in those kind of cases?
Okay, thank you. This is kind of special because the papillary edema happened in a pregnant woman. But from the question, the patient is with preeclampsia, right? The eclampsia. So I think the cause of the papillary edema in this setting is the malignant hypertension, and so the treatment is same with the emergency of hypertensive. So they have to taper the tension, but not so abrupt that it could harm the circulation of the brain. But on the other side, we also found that IIH could happen in a pregnant woman. So usually the patient is already an obese female, but then she became pregnant. In this case, usually the termination of the pregnancy is not recommended. The patient could continue the pregnancy, but the weight gain guidance should be very tight. The weight loss is not recommended also in the pregnant woman. So the OBGYN should have the patient interact with the weight gain guidance. And also we have to take notes on using the acetazolamide and topiramate in the first trimester of the pregnancy, because it has the side potential effect of teratogenicity. And also in the literature previously, there is no specific mode of delivery that should be done in this kind of patient. They can do also the vaginal delivery or the sexual cesarean, just depend on the obstetric condition of the patient.
Yeah, I think that would be very useful for all of us to know. First, we need to differentiate whether it is an idiopathic intracranial hypertension or more life-threatening conditions such as eclampsia with malignant hypertension. So, Professor Wang, do you have any experience of idiopathic intracranial hypertension in pregnancy? Dr. Yunita, Dr. Rizky, please also feel free to join the discussion if you have seen some of these cases in pregnancy.
Yes, because compressive optic neuropathy can also could also happen in a pregnant woman, right?
Yeah, among one of them.
I think the Valencia has given a very comprehensive review and suggestion for the dysedema in the pregnancy, and including the malignant hypertension-induced dysedema, and also the possible IIH-induced dysedema. And that will be different condition, and you need to control both the blood pressure and also the ICP. And there's a lot of drug contraindication during the pregnancy. And I think I cannot add anything more on that issue.
Okay. Dr. Yunita or Dr. Rizky, do you have anything else to add to the IIH in pregnancy, if you have seen any cases?
Yeah, thank you, Dr. Alia. Maybe in pregnant women, we sometimes have found a bilateral papilledema, but yes, sometimes we diagnose just suspected for IIH since we cannot obtain the lumbar puncture examination. And then just as Professor Wong said, we always correlate with the maybe that she have any hypertension or any obesity, which probably much more pronounced while she's pregnant than before. I think that's it. Thank you.
Great. Thank you so much, Dr. Yunita.
Also, I'd like to add, when IH patients happen a symptom onset during a pregnancy, usually they will relieve after the delivery. It's common to see that.
Okay.
I agree with Dr. Valencia.
So, Dr. Rizky, do you have anything else you might want to add?
Yeah, thank you, Dr. Alia. I have one cases about one case patient with pregnancy, but she complained pain in her movement of the eye. So we but we cannot do the MRI like that. So we consult with the obstetric gynecology doctor, and he said that it's okay to give her steroid injection, but fortunately the visual function is getting better, and then we delay the MRI until she delivered the baby. Maybe Prof. Gurwang, do you have comment about neuritis, optic neuritis in patients with pregnancy?
You mean optic nerve what?
Optic neuritis. So
optic neuritis.
Dr. Rizky was previously describing a case of bilateral optic disc edema in pregnancy who turned out to be optic neuritis. So is there any correlation of optic neuritis incidence with pregnancy that you might be aware of?
No, not that I know of. And also personally, I did not saw patients have a optic neuritis attack during the pregnancy. And although most of the patients with optic neuritis were female, and they may be a case for the multiple sclerosis. However, because I didn't remember that we have cases have a optic neuritis attack during the pregnancy. I think if that happens, if that would be associated with multiple sclerosis, you might be able to be more conservative, and since the spontaneous recovery rate would be rather high in the case of optic neuritis with multiple sclerosis. On the other hand, if that would be associated with so-called atypical or the NMO or other MARG-related optic neuropathy, I think especially for the NMO, the visual prognosis is not so good, and the need for the use of steroid would be very urgent. So at that time, I would suggest to consult the OBS doctors if we can use the steroid in maybe in a reduced dose to help the vision to recover.
Okay, thank you so much, Professor Wang. And moving on to the next question, I think this is the last question for Dr. Valencia. It's concerning the factors that might cause fulminant or malignant intracranial hypertension that is causing progressive visual loss. Is there any particular factors that might predispose some patients to a more fulminant nature of the visual loss in idiopathic intracranial hypertension? Do you have any comment on that?
On the descriptive studies about the prognosis of IH, there were some of the factor that could worsen the prognosis for IH, like male on older age, and also a higher grade of papilledema on onset, and also if patient had anemia. And also maybe if the patient came late to the doctor. But because the mechanism of the pathophysiology of IH is still unknown until now, I cannot answer why some people go into the fulminant type and some could have remission in 6 months, some in 1 year. Maybe Professor Wang can help me answer that.
Please, Professor Wang.
I think visual condition is usually benign in papillary edema. So that's initially we call that a benign intracranial hypertension. And as you can see that most of the patients have a good central vision and a good color sense in the condition of papillary edema. However, visual loss can occur in a chronic case of the papillary edema. If the papillary edema does not get resolved, like the patient did not receive any surgical procedure or any medication, the long-term papillary edema will cause a visual loss. However, the fulminant IIH is a different idea of the condition, and it will be associated with acute onset visual loss. So in this kind of patient, I remember that Tony Arnold has a presentation on this issue, and he talked about a certain percentage of patients will be associated with a rapid progressive lesion of the visual loss. And the characteristic for this kind of patient is that they are usually associated with a very high ICP. And according to his comment that this kind of fulminant IIH usually have an ICP over 50 centimeter water height. So you can imagine that in this kind of patient, usually the water height is, the ICP is rather high, and this is under a very dangerous condition and with a high pressure. And the patient usually will present with acute visual loss and associated with a severe headache and a field loss. So you cannot miss this kind of patient. And I think the reason for the very high ICP, nobody knows it. And but I think the problem currently is that how would you rapidly control the very high ICP and to get the vision to recover? And for the risk factor associated with this high fulminant ICP, I think maybe we need more study. And I think the case you have been shown, the case with nystagmus, the case who has a very poor vision and who has recovered a little bit back to the 620. I think that case is also associated with poor vision. However, the initial vision has been poor for him. So I cannot classify him into a malignant or not, but I think he got a very good, successful treatment, so he can get a good visual recovery for this case.
Yeah, I think that last case that Dr. Valencia presented is a bit tricky because the patient presented with congenital nystagmus, which might have caused poor vision in the first place. So the baseline visual acuity might be a problem in the assessment of fulminant or malignant nature of the condition. So yeah, it's quite a tricky case. I think I would agree with Professor Wang. So I think because of time, we need to move to the next question, which is addressed to Dr. Yunita. So there are two questions for Dr. Yunita regarding optic neuritis. So the first one would be, in the suspicion of NMO, is there some specific segment of spinal MRI that we might want to order, or should we just order the whole spinal segment of the MRI? And the second one would be, in this COVID-19 pandemic time, should we do PCR swab tests before giving the patient steroid post-therapy? Do you have any thoughts on that? And probably Professor Wang can also chip in on his thought on these questions. Please, Dr. Yunita.
Thank you, Dr. Alina, and thank you for this question. For NMO suspected patient, maybe we can order MRI for spine, but not necessary for whole spine, but only a fragment like cervical, thorax, or lumbosacral, because the important thing is you see whether there is a hypodensity or a hypoechoic for more than 3 vertebrae segments. So that will be enough. And besides, brain MRI also can help us to determine whether that's the NMO or another optic neuritis. And then for the metaprednisol steroid injection, should we do a PCR for the patient? I think that's depend on the hospital policy, because the patient, we must admit the patient. Sometimes we admit the patient for the injection in 3 days, for 3 days. So I think that will be necessary to do a PCR, but just hopefully that the PCR result can be obtained promptly, because we cannot wait too long for the result, since the patient needs the urgent of steroid injection.
Yeah.
But if the patient or the clinics can provide us with outpatient department protocol, we can maybe set that aside, because the important is we should give the steroid promptly without any delay. So I don't know about you, Professor Wang. Do you have any thought?
To my memory, to my knowledge, that there is not any associated report for the COVID-19 with the optic neuritis. Mostly that would be a cranial nerve palsy that would happen in the COVID-19. And so that would be purely a public health issue, whether the patient can get into the hospital for the steroid treatment or not. So I think different countries currently have different condition, and their policy would be different. In our country, I think mostly the patient has to prove that if he comes from abroad, and he would have to be quarantined for 14 days before he can get into the hospital, and he must have a PCR proof for a negative response, and so that's the condition. And if you were originally live in Taiwan, and then you won't have to go through that, you can go directly to the hospital. And however, if you have any concern about COVID-19, and like you have a symptom for fever or for cough or any other things, you can go for a screening test as well. And I think PCR test would be coming out in 1 or 2 days. So that won't take a lot of time. And so for the optic neuritis, that's urgent, but not so, that does not necessitate for immediate treatment. So I think a delay for 1 or 2 days would be still acceptable condition for the treatment of optic neuritis in this kind of condition.
So what about in cases with confirmed COVID-19 infection but asymptomatic, but presented with an optic neuritis? Would you still give steroid in those patients if the inpatient department allows the isolation protocol to be carried? But is it harmful to give a high-dose steroid for patient with positive COVID-19 infection with no symptoms? Do you have any thoughts or?
I think I would suggest, as you said, that if there would be PCR positive and symptomatic, and he want to be admitted in Taiwan, he would be admitted to the specific region of the hospital with a negative pressure ward and certain kind of protection. And whether the patient can receive a steroid pulse therapy, I think that would depend on his or her immune condition. You can check the immune condition first to exclude other condition, like does the patient have an intact cellular or humoral immunities, like for immunoglobulin amount and also the T3, T4 cell amount. And you can check the immune condition first and also exclude other contraindication, like if he was a case for the hepatitis or syphilis or other tuberculosis, you have to exclude that kind of infectious condition before the steroid pulse therapy. As for the COVID-19, I think I didn't notice there's a contraindication for the use of steroid.
Yeah, I haven't found any publication on that either. So I think, yeah, at least ruled out some other things that might get worsened if given steroid first. And I think the last question will go to Dr. Rizky concerning the compressive optic neuropathy. So do you have any experience on patients with compressive optic neuropathy, but at the same time had a high intraocular pressure? So the condition are concomitant. So they're both compressive optic neuropathy and also possible glaucoma condition, because it might be quite difficult to differentiate between the two that might cause further delay in the diagnosis of the compressive optic neuropathy. Do you have any experience on that, probably, Dr. Rizky?
Yeah, thank you, Dr. Alia. I forget if I have that kind of patient, but I think the two diseases can happen in one time, because compressive optic neuropathy, because of CCF maybe, or compressive in retrobulbar, can make the hemorrhagus flow terganggu, jadi membuat ini secondary glaucoma because of the compression. But I think the papil, optic nerve papil, is different between glaucoma and non-glaucoma in this kind of patients, because I think the first appearance will be papil edema, not that kind of normal or atrophic papil optic nerve.
Okay, so what about Professor Wang? Do you have any experience on patient with concomitant compressive optic neuropathy and high intraocular pressure?
I think the most common condition would be the thyroid eye disease. In a case of thyroid optic neuropathy, that would be compressed by the surrounding enlarged extraocular muscles, and usually in this kind of patient, you will experience a high IOP as well. And what you would do is first give him maybe the steroid and to control the acute inflammation, and also give him some anti-glaucoma agent to control the IOP at the same time. And fortunately, the high IOP in the thyroid eye disease usually does not affect the optic nerve very soon. So usually, I think the glaucoma is not the main issues in the management of the thyroid optic neuropathy. On the other hand, you have to keep the steroid for several months to keep the pressure, to let the compression go away, and to let the optic nerve to recover. That would be the main issue. And another condition, I won't say that would be a compressive lesion, but usually in the carotid cavernous fistula. In this kind of condition, sometimes we will be usually maybe associated with trauma. And in a traumatic case, and there will be maybe have a concurrent traumatic carotid cavernous fistula and also traumatic optic neuropathy. And usually in this kind of condition, the IOP will also increase. So you will be facing a condition with a mixing traumatic optic neuropathy and also associated with a high IOP. And also at the same time, you have to manage the carotid cavernous fistula. So in that condition, you would have to maybe if the condition permit, give some low dose steroid and to consult the neuroradiologist if they can go in and to do the embolization at the same time and to close the fistula and then to decrease the pressure and then to see how much the optic nerve can recover during this episode.
Okay. Thank you so much, Professor Wong and Dr. Rizky, for the insight. Unfortunately, because of the time, I think we have to end our webinar, our second session on the avoiding traps in optic nerve problems. So I would like to thank Professor Anbor Wong for joining us today and giving his insights on our discussion, a very good discussion we have here today. So thank you so much, Professor Wang, and I hope that we can also meet each other in real life, not through webinar or Zoom meetings.
Yeah.
In the future, hopefully.
Yeah. Sure. Thank you, everyone.
Thank you so much. Thank you. So,
thank you.
Kita telah sampai pada akhir penghujung webinar kita pada hari Sabtu ini. Terima kasih kepada Dr. Yunita, Dr. Rizky, Dr. Valencia, dan tim webinar JEC. Ini merupakan rangkaian terakhir dari rangkaian webinar JEC Saturday Webinar Series tahun 2020 ini. Sebelum saya menyudahi sesi ini, ada sedikit polling yang mungkin akan saya tampilkan. Mohon kesediaan dokter-dokter untuk mengisinya sebentar, hanya 4 pertanyaan, mungkin hanya 5 detik. Silakan dok, boleh diisi sebentar. Oke, terima kasih atas partisipasinya. Thank you so much for your enthusiasm and participation until the very end of this webinar. Thank you so much, and I hope to see you all soon in the future. Please take care, stay safe, and stay healthy. Bye.
Bye-bye.
Bye. Thank you, Prof. See you.
See you. Bye-bye.
Have a good weekend. Bye.
Wait, can we have a distant picture all of us together?
moving forward with confidence for one vision, optimizing eyesight and the quality of life. And today, this is who we are, the trusted leader eye care in Indonesia, supported by the best ophthalmologists and proven cutting-edge technology. We exceed the patient's expectations, which earned us most recent achievements. More than 6,000 cataract surgeries are performed every year at JEC, with less than 10 minutes for a patient to have a better vision. We proudly introduce our latest technology, bladeless laser cataract surgery, the one and only in Indonesia, and cataract suites markerless surgery, specified technology for cylinder correction. Also, phacoemulsification, a modern cataract procedure with the ability to make a very small incision and a comprehensive intraocular lens with the best quality. JEC provide a new technique of laser vision correction, Relax Smile. This is a minimally invasive vision correction. JEC is also the pioneer LASIK in Indonesia. In corneal transplant surgery or keratoplasty, JEC was the first eye hospital in Indonesia using laser technology as the leading edge in providing sight-saving procedure. Greater control from maximum customization. JEC provide a comprehensive treatment to children's eye disease. Equipped with a clinic that is designed to make your active children comfortable during the eye examination. Not only can eye problems solved, but appearances can be changed, such as bags under eyes. Or you may have problem with lacrimal system. All you need is oculoplasty and a reconstructive surgery to correct your eye problems. We help you to experience a better look and regain self-confidence. Good vision is a precious gift. But when you have a visual impairment which cannot be improved with regular eyeglasses, medicine, or even surgery, we commit to help you make the most of the remaining sight. Through vision rehabilitation, variety of visual and adaptive devices, and consultant may help you to keep independent. One of the most common cause of vision loss among people with diabetes is diabetic retinopathy. But unfortunately, many people are unaware of this condition. That's why we encourage you to take advantage of our program. JEC Eye Clinic with its adequate facilities serves BPJS Kesehatan card holders. It is only required physician referral letter from their primary health services, and let us assist you in taking care of the rest. JEC, as the best international eye hospital in Indonesia, initiates the fellowship program since 1998. Since then, no less than 150 ophthalmologists from all over Indonesia has attended our program. Through our corporate social responsibility, we support the government's commitment to eradicate cataract by 2020 with annual program, carrying out cataract surgeries free of charge. More important in giving an account of impression to our patient is the effort to provide best specialists as much as to provide best facilities, such as consulting rooms, operating theaters, LASIK suites, rooms with hotel services, basic diagnostic center, comprehensive diagnostic center which consists of a variety of sophisticated eye exam technology, patient education center or PEC, and more. To complete our services, JEC is located in several strategic and reachable places. Because nothing is more important to us than to serve as many people as possible for a better quality of life.